Welcome, everybody. I don't think I'm going to need this mic, but I'll put it on just in case for recording purposes. Welcome to our 2022 District Health Coordinators Conference. I think I probably know everybody here, but just in case, I'm Angie McDonald. I'm the State School Nurse Consultant for KDE. We're so glad to see you here today in person. We expected a lot bigger crowd, but I know how hard it is for everybody to get away from your district. It's just so busy right now with flu and COVID and just life in general. But we welcome everyone. Quick housekeeping, there are restrooms. As you go out into the main lobby, you'll have to go through the turnstile. Restrooms to the right. We'll have a break, but feel free to go anytime you need to. Understand if you'll have to take phone calls from your districts or whatnot, so feel free to come and go as you need. They can help you get back in through the gate if you need to. I want to just take a quick second to introduce Robin Kinney, our Associate Commissioner, and she's going to welcome everybody, and then we'll get started on her day.
Angie, it's so nice to see so many people in person. Welcome to the 300 building. The Kentucky Department of Education is housed on the part of the 4th floor and all of the 5th floor here. We're so happy that you're here today, and to our friends online, we're glad that you're participating as well. We do understand, as Angie said, you got lots of things going on in your district, and so it is hard to come, but we hope anytime that you can come in person, we love having you in person. So thanks to all your districts that have permitted you to come and travel and be here with us today. Today's agenda is really diverse, and I think you're going to learn a lot, but I think, at least for those of you in the room, you have an opportunity to reconnect with friends and see how other districts are doing. It's also a great opportunity for you to meet in person the staff of the Department of Education. So most of my staff in my office are here this morning. You'll see them kind of around the room, and they're very happy that you're here as well. This is a very passionate group. They really believe in what they do and the assistance they can provide to you. As we start the new school year, I think we really hope that this will be the school year that we lean into management of things that we've been dealing with than always being in a crisis mode. We have felt very much, I'm sure you have, along with us here at the department, it felt like we've been in crisis mode for the last 2 years. So we really hope that we're going to move from crisis into management of all the things that we're dealing with. We know that COVID, as Angie said in her email, we are living with COVID now. It's just the way we're going to do it. I was listening online last night to a basketball coach, and I think it was a lady basketball coach, and she was talking with her team just about the challenges they've been facing. I think it sums it up pretty well. She was talking about, many times we keep waiting for it to get easier. When is it going to get easier? Maybe next week it'll get easier. Next month it'll get easier. And she said, life sometimes is really hard, and it doesn't really get easier. You learn to manage hard better. And I think that's where we all are. We're learning to manage really hard situations better, whether we're talking about the coronavirus or we're talking about floods or we're talking about tornadoes that have impacted so many of your districts. We're going to learn to manage hard a little better. I want to thank all the partners that are with us today as well. A diverse agenda, and I think one thing we have learned here at the Department of Education over the last couple of years is we really depend and rely on partners. And whether it's the Foundation for Health in Kentucky, whether it's the Cabinet for Health and Family Services, we've got a speaker here today from CHFS, whether it's other partners that we have within KDE, our Office of Continuous Improvement and Support houses like the staff that help districts and you work with mental health issues, social emotional issues, and our school and community nutrition folks who are also housed in my office that work on the nutritional components of our students and staff. So we've learned a lot of reaching out to our partners. We consider each of you our partners as well. And so it is important, and we continue to invite you to reach out to any of us. If you have a question, concern, or something we can help you with, or if you're doing something great and innovative in your district that we can learn from and pass on. So I hope you have a really good day while you're here. If you are back in the Sauer building at any time, please don't hesitate to come and visit us on the 4th floor. And have a very good day. Thanks for coming.
Thank you, Robin.
You're welcome. No, it's much worse if you don't have it.
All right, and like Commissioner Kenny said, let's use this day as the time to network. We're gonna have plenty of time for questions. We're gonna have a long break for lunch. You guys can be able to go out and there's lots of places close by. We have a snack bar here that has some pretty good food. You can get snacks, drinks, breakfast, and lunch. So let's just make the best of our day. So I'm going to kind of hit the ground running because we got a lot of stuff to cover. And I want to give you guys plenty of time to hear all the important stuff, more so than listen to me. Let me just sit here then. All right. So let's say welcome to everybody. We'll do a quick poll as a group. How many nurses do we have with us here today? You're mostly nurses. Awesome. Okay. How many psychologists, school psychologists do we have? One. Okay. Social workers? No. DPPs? Any DPPs? One or other? Okay. What's your position?
We, health education and outreach coordinator for the immunization branch.
Okay. Anybody else that's awesome. Okay. All right. So next thing, how many of you, this is your first year in this position? Anybody? Any new folks? Oh, 3. Welcome, welcome, welcome. Okay. Last year was your first year. Another newbie. Okay. Past 3 to 5 years, you started in this position. Okay. Or you're an old pro at this and you've done this for 5 years or longer. Okay. So we've got a really good representation. So, and I'm glad to see so many new people because we want to be here. We want to know what resources are available to you and that we're here to help. So, I'm so glad you guys are here with us today. So we're going to talk about some beginning of the year reminders. For the folks that's been around for a while, I know you guys are tired of hearing me say this time every year, but it's just one of those things we need to cover. Is to take advantage of our free resources. We have our Student Health Services webpage. We will post, I think I've emailed all the PowerPoints out to everyone that we had at this point. The ones that we didn't get, we'll send out tomorrow or Monday, and then we're going to post everything, including all of our handouts. Once we've got them all ADA compliant, they'll be posted on our Student Health Services webpage as well. So you'll have all the hot links, everything that's on our PowerPoints. But on our webpage, we have our district health coordinator's briefcase. We have health forms that you may need, our health services reference guide. There's a link to immunization information, the Infinite Campus info that has anything you could ever want to know about Infinite Campus Health, how to set things up, how to run reports, how to build ad hocs, how to set up charting in campus if you've not done that before. Medication administration training has its own webpage. We have a new school nurse orientation that we rolled out the end of last school year that's got a lot of new modules. and it's updated. And I think even old nurses, old school nurses, could benefit from it because things change and there's new things come down the pipe. Best practice guidelines change, so it's a good review. And then our last page is our student health data, and we'll talk a little bit about what data we have available from last school year in a few minutes. It's license renewal time for nurses. If you haven't done it yet, it went live September 15th and goes through October 31st. Don't let your license lapse because it is a pain in the rear to get it reinstated, I've been told. You must complete your 14 hours of continuing ed over the past year. And district health coordinators, you need to make sure that you're verifying your nursing license for all of your RNs, LPNs, and APRNs. And we've got the link. You can do that for free on the Kentucky Board of Nursing webpage. Another reminder about the one-time CEU requirement for RNs and LPNs, may use these toward your 14 hours for this year. Advanced practice nurses cannot use this new requirement for this year because it doesn't have pharmacology in it. But we must complete something on suicide prevention and implicit bias. And it's a one-time thing. You have until July 1st of next year to make sure that you've gotten that completed. So another thing to remind your nurses of. We have a district health coordinator distribution list. This is totally separate from the listserv. This is something that I keep, and we have a lot of turnover every year. So if you are not getting emails from me from the distribution list, we have got a sign-up sheet that we will pass around and put your name and email address on there, and I will make sure to get you added on there. People that are watching online, if you're not on this distribution list, you can email me and I will make sure to get you added as well. As Sid briefly mentioned, the school health and district health coordinator listservs, those are both hosted out of the University of Kentucky. In your packet and in your handouts, there is an information sheet on how to sign up for the listservs if you are not on there already. I know some days you can get a million emails on there, but it's really a good place to interact with each other. It's a good place to share resources. A lot of times somebody will maybe say, I've got a new patient coming with such and such disease. Does anybody have a healthcare plan they'd be willing to share? So it's a good place for you guys to connect with each other. It's also, if there's any big announcements, we will post those on the listserv as well. That way you'll have access to any new things that are coming down the pike. And I do think DPH uses the listserv as well for their announcements. I really encourage you guys to sign up if you're not a member already. Mass screenings. We've had a lot of questions about mass screenings. And we are living with COVID now, kind of like living with the flu and living with strep that we do this time of year. So we have evaluated and looked at the CDC guidance. And basically they're saying if you have low incidence in your building at the time and you're not crowding huge numbers of people into an area at a time to do screenings, you may start doing your screenings again. Just do small groups. If the numbers get higher, then you may want to postpone it till things die down a little. And then, of course, we want you to continue to do anything as needed, any special ed referrals, any kids that teachers may have concerns on or whatnot. Those definitely need to be done on a case-by-case basis. But it's fine to go on and start doing screenings again. Oh, and another thing that I think that just kind of gets forgotten about, but districts need to make sure when you're doing these mass screenings that you are getting yearly consent from parents to do mass screenings. Some people think, well, the law says we have to do it, so we don't need permission, but, think about the time that we live in now, everybody's, parents have the right to say no, you can't screen my child, just like they have the right to say, no, you can't see my child in the nurse's office. So, you need to make sure you're doing that. And really, I think the easiest way to probably do it is at the beginning of the year when you do your health forms, when you have parents sign for, consent to see the nurse, add a little blurb on there that you also give, consent for the school to perform any state mandated health screenings as needed per Kentucky law or something like that. Then you're covered. So if you put it all in one little blurb, and if you want me to look over your statement or whatever before you put it on your forms, I'm happy to. But it just needs to be something very short, sweet, and simple. But to make sure you're getting those consents before you do screenings. Guidance for nebulizer treatment. I know that's a big question, and Michelle's going to talk about that in her part here in a little bit. So I'm just going to keep on moving. This information was a very, very shocking for me. My National Association for State School Nurse Consultants, and I think you probably will remember a survey that I sent out to school nurses earlier in last school year and asked people if they had time to participate to please complete this survey. And I was shocked, and it was very eye-opening, and it resonated a lot for me. It was like, it really validated a lot of the feelings that I have been dealing with since COVID. And we had a really good turnout. We had participants from all 50 states, the District of Columbia, tribal nations, and all U.S. territories had school nurses to talk about and respond. And about mental health, your mental health as a school nurse. What have you dealt with since your feelings since COVID? And so this survey reported, in conditions reported by school nurses, symptoms of PTSD, 30% of all school nurses that responded experienced PTSD symptoms. And I'm going to raise my hand because I'm one of those. And it just like, oh my gosh, that's what's wrong with me. I've got PTSD. Depression, severe to moderate depression, 24%. Anxiety, 22%. I honestly feel like that probably should even be higher. And the scary thing is 4% even had suicidal thoughts. And, over half, almost half, 45% reported symptoms of at least one mental health condition in the 2 weeks prior to completing that survey. I mean, this is just very telling, and it's scary. They also went on 48% of the people polled felt bullied, threatened, or harassed. I don't know about you guys, but I felt that a lot. I'm sure you guys did too. Angry parents because their kid couldn't play in a sporting event or whatnot, couldn't be in a school play. 39% experienced stigma or discrimination, and 24% received job-related threats. It's just bad. Other things, most people reported they worked more than 40 hours a week. They reported inadequate staffing or support or compensation, lack of peers, supervisor, or school leadership support. They felt unappreciated, worried about your workplace exposure due to COVID. Took on additional COVID-19 related job duties, notifying parents about quarantine, isolation, caring for students and staff suspected of having COVID. It goes on and on and on. So what does this mean? We spend all of our time talking about we need mental health supports for our students and our teachers, and we do. We do, but we need to take care of ourselves too as nurses. We take care of everybody else, and we put ourselves last. So this was just very eye-opening for me. Let's highlight opportunities to improve support policies and practices to try to reduce workplace stressors. And there's an infographic that I put in your handouts with this information. Share this with your administrators. I mean, I think the more we get this out there, you know, people to realize that we're all struggling, you know, the better. Okay, so any questions for me? This kind of wrapped up our end of the year stuff. We're going to talk about Intercampus in a second, but any questions for me at this point? No? Okay. Well, I'm going to turn things over to Tanya Hickman. She is our new Infinite Campus health person, and she is going to talk to you about IC updates and any Infinite Campus data.
Good morning. My name is Tanya Hickman. I've been with the Kentucky Department of Education for over 20 years. However, I'm new to the Division of District Support and to the world of Infinite Campus. And I also want to add presentation. So please bear with me, I'm really nervous this morning. So we're getting started. Nurses count. The nurse count is a report where districts go in and document how many nurses that they have in the district. We are asked about this number frequently. It shows the need for school nurses across the state. So it's very important that the numbers be as accurate as possible. Next slide. This is a screenshot showing how to enter district hire nurses, including the facts we need to follow. Instructions can be found on our Student Health Services IC webpage. And for your convenience, they're also in your handouts in your packet. Next slide.
Okay.
This is a screenshot showing how to enter contract hired nurses, including the path we need to follow. The instructions for this is in your packet as well. The student health conditions, it's very important when you enter student health conditions that you follow this chart. This allows for more accurate and consistent health records. If you encounter a health condition that is not listed, please contact us and we will help you get that entered. This chart can also be found on the Student Health Services IC webpage, and it's also in your packet as well. New to Infinite Campus is the Communicable Disease tab. This new tab allows school nurses to document each time that the local health department or other medical provider is notified of a reportable communicable disease in the field. And to access this new tab, the user access must be granted by your district system administrator, and the packet is there for you as well. Next slide. This tab, though, is not mandatory. It's not a mandatory reporting element. Districts may continue to use the current documentation procedure if they so desire. COVID-19 was added to the list of procedures as many local health departments are still asking districts to report any positive tests that they may perform. This tab is to document any point of care tests that are performed in schools, not those performed at home, and reported by parents or outside medical providers. A guidance document with instructions can be found on our KD Infinite Campus webpage. Now on to our school health data. I want to tell you guys, this is really interesting to me. Not being part of the medical field, I am amazed at the work that you guys do. Like, it's overwhelming. How many students you guys take care of a year? It's amazing. And as a parent of two children that are around school and everything, I just want to thank you all for that. Like, I had no idea. And now I have grandchildren entering, so I'm glad that you're there. So I just want to say thank you. First start we're going to talk about is the chronic health conditions chart. We were able to go back to 2014. And yeah, I don't know if you all can see the colors or not, but ADHD orange, allergies is maroon, asthma is blue, diabetes is green, and epilepsy is purple, and everything is gold. I did want to mention now that COVID year, that 1920 year is not going to be on there. So when you see these charts, you'll be able to notice that, I mean, the numbers really go down like this because of that. So So we've listed the numbers here as a reference for district data count. If you would select compared to last year's, we have them listed on our KP website. I do want to point out that the total student population represented this year was 629,723,000. So that is slide. So this continues over to the next slide. I want to point out here that the medically diagnosed by a healthcare provider, the number there was 115,639. That's medically diagnosed guys. That's people that went and to the doctor and came back and reported that. So good. The next slide is hearing data. The orange line is total hearing screening, and the blue line is total hearing referrals. Take note of the big drop in the numbers that due to COVID, and notice how the numbers are starting to come back since the kids have returned to school. I'm really looking forward to seeing the data for this next year. See what that looks like. Next slide is our vision data. The same thing happens for vision data. Notice that there's a big drop for vision screens. This is due to COVID as well. Onto dental data. The orange line is screening, the blue line represents exams, and the blue line makes reference to referrals. I didn't want you all to know the referrals that back in 2014, there was 1,003, and then by 21-22, it was down to 102. A big drop. On to Kentucky, our health office visits. I want y'all to notice the number of health office visits. Over 2 billion. That is a lot of office visits, guys. I think it's very interesting, the number of students returning back to class. Over 1 million, this just shows what a difference it makes in having a school nurse. As more students can return to class instead of being sent home. We have 135 districts. We have 135 districts out of 171 that are charting in campus. If your district is not charting in campus, we would love to help make that possible. It's even possible for districts working with health departments. So I wanted y'all to notice here, like, on a 9% home plus 0 medical equals, and EMS only equals 9% of the students left school for 91% back to class. Great job. So 91% of the students went back to class. That is amazing. There is an ad hoc report that will show you which health office visits are missing discharges so they can easily be corrected. We recommend running this ad hoc frequently during the school year so you don't have a lot at the end of the school year cleanup. We can help you walk through the process if needed. If y'all have any questions about any of that, I know it kind of went fast. I apologize. Anybody have any questions? Okay, if not, I'm going to turn it over to Stephanie.
Good morning, everyone. My name is Stephanie Funke, and I am part of the Healthy Schools team here at KPE. We are funded by federal grants from the CDC. We do a lot of professional development, technical assistance. We focus a little bit more on like physical activity, physical education, nutrition, environment, things like that. But we work under the umbrella of the whole child, so you know you're kind of involved in everything, right? There's a direct link between health services, social and emotional health, etc. So we do a lot of work with schools and districts around a lot of different areas. One of the other funding streams we have is what we call the Youth Risk Behavior Survey. Anybody familiar? Heard of that? A little bit? Some head nods? Okay, good. And you all are super special because you're the first group that's going to get to hear and see this data. We currently have the high school data from 2021, and we are still waiting for the middle school data. So CDC, as you can imagine, they're a little behind. We had to change our administration of the YRBS in 2021, and so did most states and Large school districts, so they're just a little behind. So we're waiting for it, but should be here soon. But you're getting a little sneak peek today of the data. So I want to give you a little bit of the background and process, because then you're going to be like, where does this data come from? Who answers this, et cetera. So here's a little bit of the background. Again, it's a national CDC survey. There's a national one, and then many states have their own. So the data you're going to see is Kentucky specific. And it measures all these areas. And if you look at this, you're going to see similarities to what? What do some of your districts usually survey your students? Yeah. Heard of KIP data? Kentucky Incentives for Prevention, which is an amazing data source for you as well. Not all districts participate, but if your district does, then you get district level data. So I highly recommend looking at it, because it's going to do a lot. It talks a lot about these, especially substance use, the injury and violence prevention, the suicidal ideation. So you're going to get district level data. We just have state level data, but the difference kind of between the two is ours is generalizable to all middle school students and all high school students, whereas the KIP is 6th, 8th, 10th, and 12th grade. So there's just a little bit of statistical difference. But we also look at, again, physical activity behaviors, dietary behaviors, and sexual risk behaviors in the YRBS. So it's a little bit more robust with the content that it has in it. So how we do this is the YRBS, Behavior Survey, is administered during the odd numbered years during the spring semester. So I actually usually begin this process in January of the odd numbered years. So we're getting ready, gearing up for January 2023. You're coming up in a few months to administer this again. It is usually, it's a small sample of schools and then an even smaller sample of students that participate. So we're looking at about 40 to 45 middle schools across the state that are randomly selected to participate, and then about 50 to 55 high schools across the state that are also randomly selected to participate. So it's not a huge number. And then within those selected schools, it's only usually about 2 to 3 classes. And when I say classes, I don't mean like freshman class, sophomore classes. I mean like 2 to 3 second period classes throughout the school. So you're thinking what? You know, like 60 to 90 students, maybe a little more, maybe a little less, just depends on the school. So again, it's a small number, which is why we cannot give school, district, county data, is because your district or county may not have participated at all. And then it's just such a small number that you can drill down too far and takes away for the anonymity of it. So that's how we have that. There's parent permission that goes through. It is voluntary. We work with the youth service center coordinators of the schools to administer the survey. They're a huge partner with us and a huge reason why we have amazing weighted data. But the students are also told it's voluntary for them as well. They can skip questions. They don't have to answer. We don't ever want to make anyone feel uncomfortable by anything. All right, so in 2021, we had over 2,000 students in 52 high schools across Kentucky participate. We do not release the name of schools that participate, again, because it's just such a small sample. And then we had enough percent of participation to, again, have the weighted data to say Kentucky students, blah, blah, blah. Demographics, it's pretty evenly split. Again, everything is random. It always makes me how it all works out. But even at a random sample, you're still getting, you know, it's about half male, female. The grade levels is usually, you know, it's pretty even too, split out. And then as you see the race ethnicity listed, is usually pretty the same basically of what our state is represented of. So limitations. There's always limitations to data. There's always limitations, especially when it's self-reported. So there are students actually answering these questions. There are many things in place that, you know, if the student answers A to every question, that survey gets thrown out. So it's not included in data. So there's different things, but there's a lot more limitations with the 2021 data. So just keep that in mind as we go through this. Always the sample size is always smaller. Again, self-reported. There is, for some reason, it's crazy. We always administer, right? I told you in the odd number of the spring of the odd numbered years. Well, with COVID in 2021 in the spring, there were still schools in and out, right? And the wired VS had to be administered in person, could not be done virtually with students that were participating virtually. So we postponed it and we did it in the fall of 2021. There's a huge difference in behaviors a lot of times with students in the fall than it is in the spring, right? They've been, think about ninth graders going into high school. They're kind of new and fresh, and maybe they're exposed a little bit more, and their behaviors tend to go different in the spring. You know, it's just life. So there's a difference between all the trends that we have, because we've been doing it in the spring for so many years, than this fall administration. So that's something to keep an eye on, and then COVID. We're just telling people this is a snapshot of data from fall 2021. You know, it's going to be accurate. And when I've talked to people that administer the kit, there's similarities of the trends in their data and ours. So just kind of take it lightly of any trends that you kind of see with the data. So just know that ahead of time that, you know, we're looking at students coming back to school full time, maybe just beginning in that semester of fall 2021. The effect that we've seen. The behaviors, the things they're exposed to or have access to or don't have access to, I think is going to take part. Okay, so now I'm going to get up because I told you we do physical activity. Don't worry, I'm not making you run around or anything. I'm going to give you a multiple choice question, but instead of just giving me an answer or writing it down, you have to go to the area of the room of what you think the percent is of students that participated in a certain behavior. So you're going to see it's kind of towards the middle here. There's A, B is by the back door, C is on this column, and D is up here. Just kind of move to that area of the room. So go ahead and get up, push chairs in. We're only going to do 6 of these, don't worry. I think maybe 7. I may have lied. Okay, so let's see what you think. First one. What percent of Kentucky high school students attempted suicide in the past year? So again, this is fall 2021. Before. So A was 4.2, B is 12.8, C is 1.6, D is 9.5. And for our friends online, you can guess on your own. Okay, we're moving around. Okay, we are like really deep right now. This is amazing. Okay. All right, let's see. Answer was D, 9.5. And there wasn't much different, honestly, in this data, trained data. You would have maybe thought differently, but at least for attempted suicide, this did not change much. I threw these slides in there. This breaks it down a little more. So with these, I'm telling you, there's so much data with MRVS data because it can be broken down by gender, race, ethnicity, age, and grade level. And so I stuck these slides in. We're not going to look at them right now. But I just wanted you to have them so that you can see within that 9.5, what does that look like a little deeper, okay? And these come from CDC, so it's just a little more telling of the certain percentages. Number 2, what percentage of Kentucky high school students have ever used an electronic vapor product? Vaping, 53.7, 45.1, 33.6, or 68.4? Do we not hear it as an issue? Right? This is one of those hot topics. And I love that we're starting with this data because it's going to be reflective of everything you're going to be learning about today. So it makes me excited. Okay. Are you all this way? Okay. We got a lot of D, a few C, quite a few B, and a few A. The answer is B, 45.1. Now look at this. Remember, take things lightly. In 2019, it was 53.7. This is a statistically significant decrease in vaping from our high school students from 2019 to 2021. There's no answer for why, but I think we could come up with some guesses, right? Access. They're at home where they didn't have quite as much access. I mean, again, a wide variety. So it's very interesting. So for me, when we do the 2023 YRDS and we're looking at the data, I'm going to be looking at 2019 and 2023 to see now that things are back, what that looks like. Because vaping, I mean, you hear constantly with administrators and everyone else, the issue and how widespread it is. So again, We're taking the data lightly, but it's always nice to have a number and quantify it. Okay. And that goes into a little bit more detail. All right. What percent of Kentucky high school students have ever used marijuana? So that's ever used marijuana in their life. 9.5, 23.1, 31.9, 19.2. I'm so excited. I got a lot of time.
Is that medically marijuana or recreational marijuana is what we're going with?
It's not specified on the survey, but for most children, that would definitely be recreational. We've got a couple C, a lot of B, more D's, and a couple A. All right. The answer is B, 23.1. This is B. The answer for C was actually the 2019 data. So again, this is another significant decrease in use. But now we're hearing a lot of like THC use within the vaping products and stuff. So we've actually are adding that question to the 2023 data. And again, if you have KIP data, they added that last time, so you could get your district data for that specific question. I mean, and these, they have a lot of these on there. So again, it's going to be very interesting to see what the new data will look like, but that's where we're at this point. Okay. Okay, percent of Kentucky high school students that have ever had sexual intercourse. We've got A at 30.7, B 51.8, C 44.7, D 39.2.
And I'm trying to make it.
Okay, we got a lot of B's, a little bit of A, a bunch of C's, a few D. Correct answer was A, 30.7. So let's look at this data over time. I included all these numbers because especially when you see the trend graphs that we'll have eventually online, like the number, I mean, it's just decreased, you know, and the perception of what that kids have also, and the perception that adults have is this is what's really going on. This is what they report that's going on. So the D, the 39.2, that was in 2019, and this was another significant decrease between the 30 down to 30%. But again, snapshot in time, the previous year, because they asked us for the past 12 months. And so they were home a lot more. You know what I mean? There's just COVID plays an impact on this. But think even from the 2011, so the B, the 51.8 to 39.2, that was 2019, we didn't have any craziness that occurred. It's a definite decline. And I think, honestly, that needs to be taught in health education so that students understand it's not the norm. It's not the majority. You know, so again, I'm going to always advocate for that. But, all right. Percent of Kentucky high school students that ate vegetables 1 or more times per day. How much do we think our kids are eating some vegetables?
One or more, sure. One.
We got a lot of D in. There are a couple A outliers. Got a D over here and a C. Got a lot of D's, ready?
Bullshit, 5 times a day is what they recommend, right?
Fruits and veggies 5 times a day. This is just vegetables 1 or more times a day.
Because they're counting french fries.
Well, okay. So I have wire band contrast. Takes a little bit. He's gonna change it. One of these years. They literally asked the question: Did you eat carrots? Did you eat salad? Did you eat potatoes? Not French fries. Specifically in the question that states that. And then I think it has 1 or 2 other ones. But and then they combine it to give you this percent. But yes, they can still be counting it. But 47.8. So we're still talking less than half of our kids are getting a vegetable a day. I know.
They're getting it, they're just not eating.
That's true. They have to take it at lunch, but they may not eat it. Okay. All right. Oh, I've got 2 more. Okay. Okay, so what percent of Kentucky high school students? So, you know, recommendation is 60 minutes of moderate to vigorous physical activity a day for children and youth. So, in a normal week, how many students were active 60 minutes on 5 of those days in the week? They were active for 60 minutes on 5 or more days in the week.
Is that during band season or just?
On an average, in this state, outside of physical education class. On the question, just so you know. Okay, a lot of people maybe in the state. Yes, that is correct. For C, 44.7. I broke this one down a little bit because look at the discrepancy between males and females. I think that's an advocacy. Find out ways to get the females in. They all need to be healthy, right? So what can we get their interest in? What are those daily lifetime physical activity things that they might enjoy to be exposed to a little more? Okay. Last one. Okay, so I put this in because I think this is huge for students, is the amount of sleep they're getting. It affects so many things, and we know that there's probably a major lack with all of our high school students. So, how many Kentucky high school students got 8 or more hours of sleep, which is a lot. I don't think 8 hours. I don't know about people. On an average school night, how many got 8 hours or more of sleep? A little more movement now. Yeah. Okay, we've got a lot of A, and a few B, few C. A. That's a lot of kids not getting a lot of sleep, right? And I mean, it affects their mental health. It affects their mental health. It affects their learning at school. I mean, we could go on and on, because you know what they're doing, right? They're on their phone. They're on their phone. They're on screen time. They're doing, instead they could be sleeping and feeling so much better than what they are. So, and then we've got, again, the graph. That's it. So you guys can have a seat. Thank you for playing along. We will have all the data up on our website as soon as I get that middle school data back, which will be very interesting to know also. I went ahead and put the link in here. The 2019 data is currently still available. But once the 2021 is available, it'll be on that same website. So I wanted to make sure that you had the link to it. Any questions, Jenny?
They were keeping that 19 data out and new data plans because, like you said, we don't keep looking or we could. And I just think it would be great with a free site data because we got coded.
Yeah, we could. Yeah, I mean, we can totally do that. Keep that up. I can also put I usually include the trend report. CDC sends us a trend report of over a little tidbit here. We've been administering the YRBS in Kentucky since 1997. So there's lots of years of data. And they have a huge trend report, but we can definitely keep the data up just so people are aware. Yeah, Jim.
We also have copies of 19 that we can bring down and put on the table in the back. So if you want to look at 19 data and a snapshot of a lot of different pieces of that, help yourself to it. We'll bring that down a little bit later tonight, and we have extra copies. Quite honestly, it will not be good after we get the new data for 21. So, and if you have questions like that, chat with us. Okay, happy to help.
Yeah, and that 2019 data is a really nice infographic resource book, so it's real easy to look at, really user-friendly. And again, there's a lot of detail we can go in, but we just pulled the highlights out, so we'll bring that down. Thank you all.
Thanks, Stephanie. Let's see, are our next speakers here yet? Not yet? Okay. Let's take a quick 10-minute break. We're gonna go, while we wait for our next speaker to get here and get the PowerPoint fired up. And we will, everybody just try your best to be back in here by 9:30 on the dot. Okay, we are going to move on to our next presentation. We have with us today Ms. Alicia Watley. Alicia began working with the Kentucky Youth Advocates in 2019 after completing her Master's of Social Work at the University of Louisville. As a policy and advocacy director, Alicia leads health policy efforts at KYA, including physical, behavioral, and oral health. Alicia also leads the Health Youth Ambassadors Program at KYA, which aims to educate and equip young people to advocate for health policies in their communities at the state level. Alicia has worked with Kentucky Oral Health Coalition for the past 3 years and continues to lead the coalition. Also, we have Ms. Chloe Atwater, who is a policy associate at the Foundation for Healthy Kentucky. Prior to this role, she was a staff attorney in the Kentucky Circuit Court. So I'm going to turn things over to them.
Good morning. As she said, my name is Chloe Atwater. I am a policy associate at the Foundation for a Healthy Kentucky.
I'm working on it.
There you go. There we go. The Foundation for a Healthy Kentucky is a nonprofit, nonpartisan advocacy organization and philanthropy dedicated to addressing the unmet health needs of Kentuckians and advancing policies that foster health equity.
So if you all are not familiar with Kentucky Youth Advocates, so we think of ourselves as the independent voice for Kentucky kids. So we are a nonpartisan organization, and we mostly do policy advocacy at the state level. You can see some examples of things that we work on here. So in addition to working with the state government, we also do things like educating youth. We mentioned our Health Youth Ambassadors program. We do a lot of data collection. If you all have ever seen the county data book that comes out every year, KYA produces that and does all the data behind that. And then we also try to just get advocates around the state interested in topics and working on policy with us. So the easiest way to think about what KYA does is if policy is good for kids, we support it. If policy is harmful to kids, we try to improve it. And if policy is missing, we try to create it. Oh, you can go to the next one. So,
County health data, is that what it's called?
yeah, the kids count, county data book, yeah, the kids count county data book, yeah. So we produce that, and the new one comes out in November, so we're working on kind of getting that finalized now. So we'll make sure I get that to everybody. Yeah, absolutely. So you are here today, obviously, to hear a little bit more about what's going on with tobacco and vaping in our youth. I think everyone here works in the school system in some way, from my understanding, so. You all probably see this a lot more on the ground than we do, but we're just going to go over some of what's happening right now, what we currently know, what the latest data tells us, and then kind of what are the solutions that we're looking at to help with this issue. So the first thing I want to talk about here is really just kind of what's happening and what we know about tobacco in Kentucky. We know that Kentucky is still one of the highest smoking rate states in the nation. I think we've been number 2 to West Virginia for several years. So we're really up there still with smoking in the state. And of course, that includes all tobacco use, not just vaping. But we also know that's the cause of preventable death in our state. So it leads to a lot of the preventable cancers that we have in Kentucky. And Kentucky, again, ranks really, really high across the nation as far as cancer and cancer death. So we know that tobacco is a huge issue for everyone, not just our youth, but it also is causing a lot of premature deaths. So our youth that are starting to use, in the future, we know that almost 9,000 of them are going to be dying prematurely because of their tobacco use. You can also see on here, I think it says 10 fewer years on your lifespan if you use tobacco. So a lot of this is things that we've probably been hearing for many years. But I think it's important just to reiterate it because of the high cancer death rate that we have in Kentucky, and also because of our youth are using so much younger. So a lot of these numbers are also calculated on adult use, and so we have middle schoolers that are starting to use these products. So we imagine that might even take 4 years off of their lives. I think that's it on this one. I think that's next one. Sure.
They turn down to little one.
Oh, sorry. The line, the lights, yeah.
Should we try that? I couldn't see. Yes? No.
All right, you can see the vibrant colors now. So vaping, what's the problem?
e-cigarettes are sometimes called vapes or jewels. Here are several examples of e-cigarettes. The Juul on the far left, Juul previously controlled most of this market. They were upwards of 75% at one point, I think. But they're now down to roughly 34% market share, and we're seeing a lot more of these other companies. So you have to be on the lookout for a lot more types of vapes than you previously were. And Vuse on the far right now is now the dominant firm on the market with about 35%. So Juul and Vuse are still big players in this, but everything that you see on the screen and many, many more are also issues. And what's new on the market? You might have heard about the FDA issuing regulations on e-cigarettes in 2020, and since then, the makers of these products have shuffled significantly. So you'll see things like Puff Bar, Elf Bar, Hyde, and more. And we'll cover more about this later as well.
Yeah, and so I think an important thing to note is that we all, probably a lot of you might have seen news, like she mentioned, about the FDA started to try to regulate some of these products, and in terms of the flavoring of these products. So we're going to talk more about that, but you can obviously see that they look like, I don't know, this one to me looks like a highlighter, like that's what I always think that those look like. So they're getting a little bit more sneaky on how they market these. But the other thing that we're going to note about these is really, obviously, these are not safe for kids to use. I think that we've kind of gotten away from the narrative that they are safe, but we do still have a little bit of gap in education there when we look at the data. But in addition to that, the youth initiation age is getting younger and younger. And we also know that if you start using before the age of 18, that's about 90% of tobacco users are starting before they even turn 18, the ones that are going to be lifelong users or long-term users. If we can get people not to use any tobacco products before they turn 26, they're likely to never start. So preventing that initiation at a young age is really important, because if they can get into their 20s and never have tried it, they probably won't start using these. The other issue that we're seeing right now is that these products were initially designed to help smokers stop smoking. So the manufacturers are calling them a cessation device, and they have been for many years now. And in some cases, that is a harm reduction strategy for adults. For kids, that is not the case, and we're actually seeing the opposite effect. So kids are starting with these products, and kids who have never touched a cigarette will never touch a cigarette or would have never. They're going to start using these products, they're going to get hooked on the nicotine that are in them, and then they're going to move to the combustible cigarettes. So it's actually taking the opposite direction of what the manufacturers are talking about. And then the other thing to note is that some of these products are actually leading into harder drug use as well. So when we talk about the brain being rewired for addiction purposes, if you get hooked on nicotine, that can then lead into other drugs. So not only traditional cigarettes, but other things as well.
So explosive growth and kid-friendly flavors. So as Alicia indicated, e-cigarettes were purportedly developed to help smokers quit. For a long time, from the advent of e-cigarettes, we didn't really see people using e-cigarettes in this recreational fashion. And then in the mid-2010s, according to the FDA, in 2018, 1 in 5 high schoolers used e-cigarettes nationwide, which is a 78% jump over 2017. So what happened? Why in the span of only a few years does these products blow up? And the answer is that Juul happened. So in addition to these devices being rechargeable and sleek, they packed a much greater nicotine punch than previous e-cigarettes and came in flavors that appealed to young people. And this just really changed the game. So while the landscape has changed in terms of who is controlling the market, the flavors are the key to understanding why e-cigarettes seemingly exploded overnight. And these flavors are a trap. We know that according to the American Medical Association, 4 out of 5 kids who have tried e-cigarettes started with flavored products. The FDA banned flavored cigarettes in 2009 because they appealed to kids, but it has yet to fully ban flavored e-cigarettes. Meanwhile, tobacco and e-cigarette companies are selling flavors like cotton candy, bubblegum, and unicorn wood. E-cigarette makers know that nearly 90% of tobacco use starts with youth. And in order to rebuild a customer base that they have killed, they're starting with youth. So with all the talk of these flavors, and we previously alluded to it a few times, the FDA did try to regulate. So what happened with that? What those were restrictions on flavored e-cigarettes. So limiting flavors to tobacco and menthol, but it only applied to closed pod systems. So like Juul, and exempted other types. So companies were free to continue to make these flavored e-cigarettes as long as they complied with that regulation. And what we're seeing here, that the FDA did not explicitly regulate synthetic nicotine until earlier this year. Even though synthetic nicotine is not any safer than tobacco-derived nicotine. So we're seeing oral nicotine pouches, just this advent of all of these new products that skirt the restrictions in order to continue to host this new generation of kids. And really it's a game of regulatory whack-a-mole. So the second that we know what is taking hold with kids, and the FDA comes out, from the time that they decide to regulate something, it probably takes about 2 years, sometimes more, for those regulations to be enacted. So they can't act fast enough. And that's really what we're seeing here with this game of regulatory whack-a-mole.
Yeah, absolutely. And you all have probably heard more about Juul because they've been in the news more. They've been sued the most, I think, of any other company. And we're going to talk a little bit about a settlement that just came out recently later in the presentation on that. But like she mentioned, they're very well aware of what they did, and they've actually admitted to that in the court because they're settling on the case. So you can go to the next slide. So the other thing that we want to touch on is what's in these products. When they first came out and we first started hearing everyone calling them vapes, we had definitely an education gap on vape. We had a lot of kids like, oh, it's water vapor, it's no problem. I think that has largely changed. I don't think anyone's under the impression that these products have water in them at this point. But I do think that there is still some misconceptions about maybe what's in there and how harmful it really is. So I know this might be a little bit small to read, but there are some things that we know are in these products. Obviously nicotine, which is the addictive substance in there, but there's also cancer-causing chemicals, like I mentioned. We also have hard metals that they're ingesting directly into their lungs. And then down here at the bottom, those flavors. So although the flavoring itself might be a legal substance, it's really not designed to be inhaled into your lungs. So it's doing something different in your body when you're inhaling it into your respiratory system and into your lungs than it would if it was flavoring a food that's going through your digestive system. So that's another problem that we're seeing with that. So that can cause a really serious lung disease as well, in addition to the risk of lung cancer. So those are just some things that we know are in these products. There's also a lot that we don't know because there's no one regulating what goes into them. Like she mentioned, the FDA has had a really hard time keeping up, and they're really not doing a great job of regulating it right now. So it's really hard to say what's in the products. The other thing that I will mention is coming up more and more, you might have heard about this recently, is THC in these vapes. You're probably seeing heads nodding around the room, so you'll probably see this a lot. There's another loophole in some policies around how we're driving hemp. Hemp is legal in Kentucky. So they're deriving that a few different times to basically get to no longer hemp, and now it's THC. And they're putting that in vapes. And so we're having problems with that. Obviously has very different impacts on behavior and immediate, intake. So that is something that's coming up a little bit newer. But in addition to all of these things, we don't even know what else is in it because there's no one regulating what they're putting in these products. But we know it's not water vapor. So that's something that is a misconception that came out several years ago. I think we're good on this one. We're good on this one. So this is some overviews of the risks. I think it's pretty similar to what you've heard for many, many years about tobacco and smoking. Impacts every part of your body. So you can see all the way up here from brain to the oral health is definitely impacted. She mentioned that I work with the Oral Health Coalition.
We hear from dentists about what they see in the mouth all the time from vaping. That's obviously the entry point, so that has a lot of impact. And then you can see pretty much every system in your body is impacted when you're using this product. These are all the cancers that we know are associated with the use. And then over here, this is a little bit newer because it's all about COVID. So more likely to get COVID if you're smoking, and then if you're using e-cigarettes and conventional cigarettes, even more likely than that. And then if you kind of dig into this research a little bit further, it also talks about the severity of COVID when you get it. We know that that varies so much, so you're more likely to have a severe case. You're also more likely to be hospitalized. And I think this tracks pretty well because it is a respiratory disease, and we're talking about smoking in the respiratory system. So not really a big surprise there, but they have had a chance to now kind of dig into that and look at those connections a little bit further. You can go to the next one. So now I'm going to talk a little bit about the most recent data that we have, and I'm sure many of you have seen this. This came from the KIP survey last year, so some of your all schools might have participated in the KIP survey. So we now have all the results from that. And this graph is a little bit confusing to look at, so I'm going to walk through it a little bit. The purple is the e-cigarette, so that's kind of what I'm going to focus on here. So you have the darker purple is Kentucky, the lighter purple is the nation. So obviously we saw the huge jump back in about 2019 when e-cigarettes completely exploded and everyone was trying them. And then it has gone down. I think that has to do with a couple of things. I think that the first time these numbers were captured was probably when everybody was trying it at least once. It was kind of the new thing to do. And then we have gotten a little bit better on education among students on it, the risk perception. That has gotten better. So I think some of them kind of understand those risks now. In Kentucky, you will see the numbers look like they've gone down as well. But it's dotted line. I do not work for Reach Eval who did this, so I would encourage you all, if you have questions, to reach out to them, but I will tell you what their disclaimer says about KIP this year. They had to push it off a year, so it's supposed to follow the same KIP every 2 years. But because of COVID, it did not do that. So it was in 2018 and then 2021, instead of 2020. So it's not following the same kids directly, so directly comparing those numbers is difficult, and it's probably not the best way to read the data. The other thing about that is that they had different schools participating. JCPS, for instance, did not participate in 2021, so we know that's a big group of our kids around the state. They have a large number of students. So there's a few reasons why these numbers could look the way they do. It's possible that these numbers, they have gone down a little bit, but I think it's still a pretty big issue, and we know that I think among 12th graders, I think it's like 1 in 4 are using at least, because it's self-reported, so some of them might not tell us that they are. And then I think among 10th graders, it's at least 1 in 5. And then if you go all the way down to 6th and 8th graders, there is still use being reported. It's not quite as high as it is in those higher grades, but we do have a lot of middle schoolers that are using. And I was actually at a youth retreat this week, and I had one of them tell me that their parent is a 4th grade teacher and that she's taking vapes in her classroom. So that is 9 and 10-year-olds that are somehow getting these products and bringing them into school. So we know that's happening. That's anecdotal, of course. I don't have any data to back that, but we know that's happening around the state as well. You can go to the next one. So, and we also, I should mention on that last slide that Kentucky has consistently been, other than that one spike, we've been higher than the national average for a bit of time now. So we still remain higher than the national average. And last year, you can see this on KYA's data from last year when we pulled it. We actually had the highest middle school rate among states that were reporting that in the last couple of years. So this was also asked on the KIP survey this year. I think this was one of their new questions. They have not asked this in the past, so that's why you won't see any comparisons to previous years. But they asked, how are you getting your vapes? Where do they come from? So again, keep in mind this is self-reported, so they might not want to really tell us. But a lot of them did, and borrowing them was obviously the #1 thing, so that doesn't really tell us where they came from. But I think it's important to note up here at the top, almost 25% of them said they walked into a store and they purchased it themselves. So I thought there was an edge limit. Is there not? So there is, and we're going to talk a little bit more about what the solutions are there because that's a regulating issue with our stores. That means our stores are selling underage, right, to 25% of the kids that use these products. So we're going to talk a little bit more about that at the end when we get to solutions. But yes, 21 is actually the legal purchase age for these products in the state. No longer 18, it is 21 now. Oh. So that's a huge issue. That's a huge gap, right, that we can solve right at the source of where you buy the products. You can see the other percentages here, but I just want to note down here at the bottom, I got them some other way, and we don't know what that is. So they didn't have to go into detail about what that was. again, it's self-report, we're talking about kids, so I'm guessing a lot of them are like, I'm not gonna tell you where I got it, someone else gave it to me. But when we look at these numbers, I've also talked to several like school social workers and other folks in schools who are working with youth who try to quit and are actually talking to these kids. And I'm hearing, again, anecdotally, there are some instances of parents giving them to them. I do hear that. I do hear people telling me that the kids are saying, oh, my parent gave it to me. And a lot of times we talk to the parents if we're able to, and they might say, well, it's better than cigarettes. So again, we have an education gap on it. The parents think that they're kind of doing a harm reduction thing by saying, like, if I give them this, at least they're not using something else. And so I think there's still definitely a gap in education there. But just thought this was interesting and definitely can give us some ideas of where to start to stop these products getting into the schools. You can go to the next one. So these are a few examples, and we have many more later on in the slides that are more of our policy examples. But I think it's important for us to think about these things that are on the screen here on what could we be doing. So embracing tobacco-free schools, most of you probably work in a district that is declared tobacco-free. I think we are at 97, 99% of the districts in the state are declared tobacco-free. A very large number are. So making sure that that's being enforced in your district. I heard yesterday from some youth that they are a tobacco-free school or a tobacco-free district, but they still have a smoking area for staff. So, like outside the building, obviously, but if you're a tobacco-free school, your whole campus is supposed to be tobacco-free. You're not supposed to be able to do that. So there might be some enforcement issues happening in districts like at that level to actually be a tobacco-free, school or campus. And we know that creates a model environment. So if they see their teachers outside the window smoking, that's really not going to help with their behavior as well. So that's one thing that we can be doing. And also there's some ways to get like signage and things. I think Chloe's going to talk about that later if you want more of that for your district. Cessation programming, I think is really important, and it's really underfunded at the state level. So we have a few options for cessation for kids that are already using, they're already addicted, but that needs to be expanded. I think that we need more money put into that. We're going to talk about that a little bit later, but making sure that we have that available. And I added in here, making sure that we're addressing the root cause of their use, because just addressing the fact that they're using is not going to stop that, because there's a reason they're doing it. And I'm going to get a little bit more into what can come behind that, but there is a reason that these kids are picking up these products. And so if we're not addressing the root cause and they're going to be going back to that, we're finding something else to address that root cause if we're not doing it. So obviously there's some opportunities to look at how the public health standards are being met and these products being manufactured. That's not something that a lot of us in this room have a lot of control over. Again, that's the FDA kind of regulating the makers of these products. And that's been pretty challenging here in the last few years. Big tobacco, I'm sure you all have heard that before, and for years and years and years, cigarettes has more money than almost any other industry. So when they lobby for what they want, they often win because they put so much money behind it. It's pretty difficult to go up against them. So that's something that we continue to work on and continue to look at. Obviously, the youth appealing products and the flavors that she talked about earlier. So closing those loopholes in the law to make sure that flavors are actually banned and not just banned on a few products that then they stop making and choose something else. So we can really expand out the flavor bans and the names of the products and how they're marketed. Let's see here. So we talked a lot about education gaps. There are still, I want to say from the kids last year, something like 35% of students were still reporting that they didn't think it was harmful to them. So that has gotten better. When these products first came out, almost all of them said they were not harmful, but now it's only about 35% say that. So we're getting better, but I still think that there's room for improvement on making sure everyone really does know the dangers and kind of understands that. And again, this also extends to our parents who are maybe handing these products out or enabling their kids to be able to use them. And then the last one here is controlling the sales, marketing, and distribution. And there's ways we can do that with policy. So we're going to talk a little bit more about that at the end, but making sure that we're looking at kind of from all angles. So in the schools, in the federal government, how they're regulating, providing cessation, educating people on this, and then also looking at the point of sale and how people get the products. You can go to the next one. So I'm going to get into that root cause discussion just a little bit here. I think everyone in this room is aware of the crisis in mental health we have among our youth. I don't think anyone is unaware of what's going on with our kids right now. The U.S. Surgeon General has declared youth mental health as a crisis right now. And that is happening across the U.S. and here in Kentucky as well. This is also from KIPP last year. So during the pandemic, they're asking about how youth mental health has been. So things like stress, anxiety, depression, and these are the kids that answered, I was, had poor mental health most of the time or always during the pandemic. So if we look at our 12th graders, 40% of them say the entire pandemic, my mental health has been poor. And so you can see the numbers go down there, but we're talking about kids that are in 6th grade that are already experiencing this. And so imagine as they're getting older, they have more stress, more pressure. It's going to get worse unless we address it. So I just want to point out that this is out there. The data is there to support what you are seeing in your schools every day. And we also know that they are using these products to self-medicate for mental health reasons. You can go to the next one. So, like this one says, vaping has now very strongly been linked to mental health in a lot of our students. It's not like every student, that's the reason they picked it up. A lot of them tried it because they thought it was cool, and then obviously the nicotine gets you hooked. But when we talk about an addiction, that is still a mental health concern. That is still something that can be addressed from mental health supports. So there's a few things on here that I wanted to mention that I think can be done. Number one is if you follow the federal government's, when bills are passed at all, or if you saw the news over the summer, you probably saw this. There was 2 huge bills that were passed federally over the summer that put a ton of money into mental health for kids. One of those was their gun safety bill. So everyone probably saw that in the news after the shooting that happened over the summer. They brought down that bill that was really about school safety and gun safety, but if you look down in there, it has dollars allocated for mental health support in schools for kids to address violence and other things that are happening. So Kentucky really needs to leverage those dollars. So if you're somebody who is interested in advocating for how Kentucky uses, how Kentucky's government operates, we need to be talking to our federal delegation, so whoever represents you in the federal government, and telling them to make sure that we're leveraging dollars that are available to Kentucky for mental health support in schools. So 2 big bills that came down around that. The second one on here is that Juul settlement that I mentioned a minute ago. So this just came out like 2 weeks ago, maybe. Juul settled on a lawsuit that was all around them basically saying, hey, sorry, we caused all of the youth to become addicted to these products, and we're going to give out something like $438 million to the state to fix this problem. So Kentucky is on the list to get money for that. We don't know exactly how much Kentucky will get yet. That's not been released. And when it comes in, technically our attorney general will get that money. It's not allocated yet to anything. So it's likely it could happen that he puts that to the legislature. And so all of our Kentucky state representatives and Senate members will have the ability to choose what happens to that money. So KYA stands, I think the foundation stands as well, is that money needs to go to helping these kids that are addicted to these products and to preventing future use. So if we're not using that money to go back into the problem, I think that that's a waste and a missed opportunity in my opinion. So we're really going to be working to make sure that that goes into prevention and cessation efforts. But in addition to those, addressing their mental health concerns at the same time. Because again, if we don't address that, they're going to continue to use or find a new product. So that's super important. And then the last one on here is going to be something that you're probably going to start hearing more about because KYA is going to work on this next year. It's around the 988 line. Hopefully everyone knows about that by now. Over the summer, the suicide hotline changed to be 988 instead of the 10-digit number. So 988 is already operational. That's great. Last year in the legislature, they gave us funding for 2 years in the state budget to kind of get that up and running. It already existed, but it's to just kind of make sure that capacity is there and that we can provide the supports people need around the state. But that is not a sustainable funding mechanism for that line. So if we don't have sustainable funding, then a lot of those calls will end up getting routed out of our state. So you're not going to get a local person when you call that number. Right now, Kentucky's doing great. We have over 80% are routed in state for those calls. But if we don't have sustainable funding for capacity for that, then we're not going to be able to take those calls locally, which is really important. So KYA is going to be working on a bill that will hopefully put in a sustainable funding mechanism for the 988 line next year. So you can be looking out for that. And that's something that every student has access to. It's call or text that's anonymous. So it's a really good support, and I think that students really appreciate the texting option. So they can just message with somebody that can help them with that. And when we talk about mental health, a lot of times we think about this as like a suicidal person or somebody who is like in crisis for a mental health reason. But if we have somebody who is addicted, so a substance use disorder, they have the ability to use that line. So if you're addicted to nicotine and you're trying to quit, you can reach out and say, I'm having trouble, here's what's stressing me out, whatever, I'm trying to quit these products, what can I do? So that's another reason why it's important to put money into that line. You can go into the next one. Go ahead, sure.
Should you all need resources, these are fairly accessible videos. The foundation a few years ago put together this series of videos titled I Just Didn't Know. Because what we were hearing from kids was that they just didn't realize that these were harmful products, because at first they really didn't. I think that has changed some, as Alicia has alluded to. I think that they, by and large, do know that it's harmful now, but when you're that young, even if you know something consciously, that's maybe not something, you're not necessarily prepared for the ramifications of those decisions. So if you do need an easy resource to show kids, it's ijustdidn'tknow.org. They should be good. Move forward here. And sadly, many Kentucky youth are already addicted to nicotine. They can hardly sit through class without taking a hit. We hear about, kids putting their vapes in their hoodie sleeves. So there are resources that exist for kids that are already struggling with nicotine use. And it's hard to see here, but it is that they can text Ditch Vape to 88709 to learn more. Quitting is really hard. It's a lot easier to never start in the first place, but there are structures in place should they need that. So you can take that information down if you don't have that already.
The other thing you can look at, and this is one I thought was really underfunded, but you can ask the health department in your area if they offer prevention and cessation. Not all of them are funded to do it because we don't have a funding in the state budget for it, but some of them are. So if you're not sure, just reach out to whatever health department is in your area and see if they have any available resources. I've also heard a lot of them are really good about partnering with schools to bring somebody into the school to help or do classes or whatever it might be. And then the other one I wanted to mention was the Icons and the Trends from UK. I don't think that's on a slide, so I'll go ahead and mention that. But UK does a program with college students as peer mentors for high schoolers, and they have, well, actually for any age, they do elementary, middle, and high school. They have really good success with that program, and we find that I think a lot of the students are more receptive to talking to those peers that are closer in age to them. So if you're interested in that, they have, so it's UK Icon and the Trend. You can look that up, or we can send it in the follow-up as well, but they have a really good program as well, and if your school district's interested, they can bring in those students and do some programming in your school from UK. So there's a process to get that as well. I forgot to put that on slide, but it's a great resource.
Yeah, they're awesome. But we do want to talk about some of our policy wins and some of the future plans that we have here. As you all are probably aware, statewide tobacco-free public school campuses passed in 2019. And the map here is school districts that were covered by a tobacco-free policy prior to the passage of House Bill 11 and after House Bill 11. So by that time, 98% of districts were covered, and the opt-out period, so if it wasn't a blanket, every public school has to do this, but there was an opt-out period. So anyone that didn't actually submit a request to not be included in this is now covered by that policy. Now, as we talked about earlier, enforcement is a problem, and how those are being enforced is probably a patchwork, but there are resources available for that. One thing that the foundation did to reduce barriers to participation in tobacco-free public school campuses was that we've created free signage for schools. And I will give you all my email information will be at the end. And you all can send me an email and say, hey, I need those resources. And I'll put you in contact with my colleague that oversees that project. But we just wanted to make sure that it wasn't a financial barrier for any school to advertise, hey, this is the tobacco-free campus now. The other thing that we wanted to mention was Tobacco 21. So a few years ago now, 2020, correct? Or 2019? It was 2019.
It was 2020. It passed federally in 2019 at the end. So in 2020, the state codified that.
So in 2019, the federal government raised the legal age for purchasing tobacco products to 21, and the following term, the Kentucky legislature raised the legal age in Kentucky to comply with the federal restriction as well. So it is now, in fact, illegal to purchase tobacco products under the age of 21, including e-cigarettes.
But as you mentioned, or as we saw earlier, they're still buying this.
Which is what we're about to touch on here. So, a few of the future plans, licensing requirement for tobacco sales. Your question earlier hit on this. It just teed it up really nicely. So we finally come back to knock that one out, of course. All right. So for alcohol, you all are probably familiar that there are requirements for licensing. You've heard of ABC cops that will crack down on people who sell alcohol to minors, the minors who purchase alcohol in liquor stores. And really, that's just not something that we see that much of because there are restrictions. We know who sells alcohol, and they know that they stand to lose a lot if they sell to minors and they get caught. So what's happening with tobacco is that because there's not a licensing requirement, any convenience store can sell these tobacco products. And even though they're required by both state and federal law not to sell to people under 21, it's really hard to find out that that's happening. And as a result, we're just not seeing the same level of enforcement with tobacco. So that's something that would go a long way with the state legislature. That's what that would require is a change in the state law to require licensing for tobacco sales.
Sure. I was going to say, KYA is working on this effort for next year as well. So just to dive in a little bit more to the details on that, we really just want to mirror it to what they have to do for a liquor license. And everyone knows what a liquor license is and what that looks like. So like she mentioned, that's on the store owner or whoever is bringing in the income to keep up their license. Tobacco sales, you don't have to be licensed, as she mentioned. And so part of the issue is we don't know who's selling, so it's going to give us data. But right now, the enforcement for underage sales is, again, a patchwork. We see this a lot with tobacco issues. So one thing that they do right now is we have some programs that do like mystery shoppers. So you send a plainclothes enforcement officer in with a youth that's underage and see if they'll sell to them. And they do that here and there around the state. It's not a comprehensive program by any means, but it's pretty much like if they didn't sell, then it's great. You get a pat on the back. Good job. If you did sell, you get like an education talk from the officer, like, hey, don't do that again, you know. So that's great that they're doing those things, and that helps us kind of have an idea of how often it's happening, at least to some extent. That's one thing that happens. If you call and report a store to your local law enforcement and say, hey, I know they're selling underage, that law enforcement agency might follow up on that, and they can cite the store and give them like a fee. It's not like a criminal, anything, but it's like a fee. But a lot of times it is the clerk that sold that has to pay that fee, not the store owner who actually cares about the bottom line of their business. It is the kid that is 25 that's selling at the store that has to pay that out of his paycheck. So that doesn't impact our owners at all. They're going to just get another clerk if that continues to be a problem, right? Like that doesn't impact their bottom line as an owner. And the other thing is that the FDA, which is our federal, obviously regulatory body, can enforce this. But as you imagine, the FDA is not coming into Kentucky stores all over the state and actually doing any work. They don't have capacity or people to do that. So you can go online and look at how many stores were cited last year by the FDA, and it tells you what happened, what the outcome of that was. And I think like 98%, maybe 99% of them got a written warning. And when the FDA gives you a written warning, they send you a letter like 2 weeks later in the mail. They don't even send a person with it. So as you can imagine, that doesn't really do a whole lot. We don't see a lot of change in the behavior from that. So those are just some examples of what happens right now. And so we're hoping that if we can mirror it to a liquor license, it's a strike system. So you do it once, you might get a warning. You do it again, you get a pretty heavy fine. And if you do it again, you lose your license. You can't sell again. So that's going to hopefully cut down on those youth sales and that 25% of kids that say they're walking into the store buying them. At least we would hope so, because like she mentioned, alcohol, I don't think it's nearly as big of an issue because they don't want to lose their liquor license because that's their income. And it's the same thing with cigarettes. Anywhere you go, they make a lot of money off of cigarettes and tobacco. So I just wanted to add that in because I know we've been working a lot on this. So give you all an idea of what's really happening.
KYA has been at the forefront of this. Another future plan is restoring local control. So you might have heard of statutory preemption, and people's eyes tend to glaze over when they hear the word preemption, so I try not to use it too often. But the upshot is that the state determined a long time ago that individual counties and towns cannot regulate the marketing and sale of tobacco products within their borders. So if your community doesn't want a vape shop across the street from a middle school or a high school, they can't do anything about that. And this is one of the primary ways that we really can see an impact, and restoring local control would allow for different priorities across different communities. You know, you want to talk about local freedom, that's local freedom to me. So restoring local control is a priority. It's a really difficult thing to achieve, but advocates in Kentucky have been working on this for a really long time, and hopefully someday we'll do that. The other policy that we wanted to cover was statewide smoke-free. So Kentucky is one of only 13 states without a statewide smoke-free indoor air policy. That was a mouthful. But basically, individual counties, fortunately, the Kentucky Supreme Court held that that counties can say you can't smoke indoors in restaurants, but the states can't do that right now, or they have not done that to this point. So you might drive across county lines and end up in a space where you're getting secondhand smoke without realizing, like, oh yeah, this is weird, this is a patchwork. So that's what's going on with statewide smoke-free. Do you have anything to add for local control or smoke-free?
No, like she said on local control, we did this for the last 2 years, didn't pass. Last year, lobbyists when they spend their money is public information, so we kind of track who's working against any bills that we're working on, and Big Tobacco was really against the restoring local control last year, so that was something that we saw. So we kind of know that there's efforts against that, but it's definitely something we're still interested in trying to do. Yeah.
The other aspect to the statewide smoke-free is that 3 in 4 Kentuckians support a comprehensive smoke-free law in Kentucky. So this is something that does have really popular support, and as a result of big tobacco, our legislators are just not willing to take that up. So hearing from as many people as possible, like prioritize our kids over big tobacco, is going to be really important if we're to see any change in these policies in the coming years. All right, so I wanted to make a shameless plug here. What's happening in your school or community? And in addition to my work on tobacco at the foundation, I also work on the Kentucky Coalition for Healthy Children, and we have a monthly newsletter. Part of that monthly newsletter is that we promote any interesting projects or programs that are going on in Kentucky communities or schools. So if you have a really great school garden, or if you have a cessation program at your school, I want to hear about those. So please email me. The other thing to email me about is the signage for the tobacco-free school. So please let me know if you need those. They are free. We don't want that to be a barrier to anyone enacting their tobacco-free school. That's about all that I thought. So thank you for listening to us today, and I'll hand it over to Alicia.
Yeah, awesome. I'm actually gonna stick around for girls' next couple sessions and just listen because they're definitely relevant to us. So I'll be around if anybody has questions for me, but yeah.
Why is the legislation tobacco and not tobacco only?
So that's a good point. We talk about those somewhat interchangeably, which I think there's a lot of people who think of those products as being the same thing, but generally when we write the actual policy, we make sure they include nicotine products as well. We just tend to talk about it as just one, but that's a good point. Yeah, we're trying to be very specific in the actual language of legislation to make sure it encompasses all these products because we've seen at the FDA level that they don't do that, and then we end up getting these, new products that don't fit into those policy. Yeah, good point.
The regulatory whack-a-mole. You got it. That's the take home.
Very challenging. Anybody else have a question before we wrap up? And I'll also share my contact info if you want to share it out to the group afterwards.
Okay.
As well. Thank you all so much.
Thank you, ladies. We are gonna take about a 10-minute break, but I do want to say, that we have some freebies back here in the back of the room. Compliments of the Department of Public Health and our Healthy Schools team. I think maybe even has some, resource books, for the school nurses, so go by there and check them out. We will start back at 10:30 on the dot. So we'll see you in a few minutes. Thank you, everyone. We are going to move right along into our next presentation. With us, we have Dr. Kimberly Hansford. Dr. Hansford is a board-certified pediatric dentist with 24 years' experience in the treatment of children and special needs patients. Her special interests include hospital dentistry, nutrition, and treating special needs populations. She completed her undergrad at the University of Kentucky before attending dental school at the University of Louisville. Before completing her fellowship in pediatric dentistry at Cincinnati Children's Hospital. She worked as a professor in the University of Louisville School of Dentistry, Department of Orthodontic, Pediatric, and Geriatric Dentistry for 7 years before going into public practice. And most importantly, she is my cousin / baby sister that I never had. And, no. And the reason my boys have beautiful teeth. And she's also an honorary member of the National Association of State School Nurse Consultants. We adopted her at a meeting in Utah. So,
I learned a lot that.
She's a school nurse at heart. So, I'm going to turn it over to Kim, and we're going to learn a lot today.
Thank you. Thank you. That was a mouthful. Well, thanks for having me. I'm excited. And I'm newly retired, so I have lots of energy for this.
So the new term is rewired.
Right. I was blessed with a horrible, I don't know if it's my job or my badging, but I have a horrible spine. So 25 years of dragging kids around, not been friendly with my back. So I stepped away from my clinical practice. And I have a little more free time than I used to. So I'm happy to be here. I did teach for 7 years at U of L, so I've got lots of slides and lots of stuff to put together, and I'm happy to bring it back out and share a little bit with you guys. So I started and kept moving north and came back to Louisville and taught and did private practice there and have stayed there, and I'm happy to come out today and share a little bit with you guys. Hopefully I don't ruin anyone's breakfast. There's a little bit of blood, not too much gore, but I'll swap some stories. So today's goal is just kind of prepare you not to have just any treatment, to kind of appreciate and refer and
maybe stabilize a little bit. There's one thing I might ask you to do in this lecture at the end that is a little bit of treatment, that could really help someone out. But kind of just recognizing what's going on, kind of getting things cleaned up and figuring out what to do from there is kind of the big goal here. Or at least that's what I was told was the goal. So that's what I'm going to prepare you for. First of all, just know what should look normal, where you start. And I'm going to go over a little bit about, in most instances, I would guess what most people in your areas are going to be dealing with are not a lot of small children. Is that true? Not a lot of 2 to 4-year-olds, right? Preschool, right? You do have your 4-year-old. I was thinking you were older. That's cool. So again, no one wants a baby tooth unless permanent tooth is a big deal. Maybe in a school situation where someone falls and has a tooth come out, like a baby tooth, it's a permanent tooth, that could be like a huge deal. So we'll talk a little bit about that along the way. What's normal? In baby teeth, ideally, you've got lots of nice pink healthy stuff, and there's no big gaping brown goo with cavities, things like that. This is a nice healthy kid, but obviously they don't all look like this, but nice space and gaps and healthy gums. It all looks pretty. Baby teeth are really, really white. Permanent teeth are a little bit yellow. You'll see that as we go along. So when you're trying to tell what's what, baby teeth are flat and square and very, very paper white. Permanent teeth are a little more yellow and kind of wide, and we'll compare in a second. But they're short and flat and square, whereas permanent teeth are not. But short and gappy and lots of space. Most kids up until around kindergarten are hanging on to these little front teeth. It varies quite widely. A lot of times girls especially are faster, not always, but they tend to lose teeth faster. But, you know, there may be 4-year-olds that have permanent front teeth, and that happens. But kind of generally 5 and 6-year-olds are losing front teeth, and things are coming and going, and they're showing up like things hanging by a thread. And I know most schools have a nice those little like tooth boxes, and everyone is so excited to lose tooth at school so that they can get a tooth box to take home. I know my child was. He spent more time in the nurse's office trying to lose a tooth, and she would always be like, "Isn't your mom a dentist? Like, why are you coming to see me?" Because that was his goal. And if you lose in the cafeteria, that was even a bigger deal because everyone saw it. For mixed dentition, the next stage, you've got half and half, okay? So around age 6 to 10, 12, somewhere in that range, you've got a whole mixed bag. These are the kids that are probably the ones that are going to be having the most issue. These are the ones that are falling, that are breaking things, that are the most active, that are probably going to have the most higher risk traumas in a school setting. And again, these are the ones that are probably have a little more on the line. Most trauma situations happen in front teeth. Just because they're sitting out here, they're like begging for something to happen in the fall, right? They're like, you fall face first most of the time. That's the biggest risk. So you can see these are permanent teeth. They're big and wide, and they're yellow, and that's what most parents complain to me, like, my kids' new teeth are so yellow, they're so ugly. It's just because you're used to seeing those little pretty baby teeth that are like the color of a sheet of paper and don't match, and you get this new tooth that looks so different. When it all matches, it doesn't look so ugly anymore. But when they're sitting side by side, they always look kind of yellow, but it's just the way the teeth are made out. They're a little more dense and look a little darker. But a permanent tooth is going to be a lot more yellow. And you can see these little bucks on the edges. They're called mammal lines. Baby teeth don't have those. So that's a good way to tell when you're trying to figure out, is this a permanent tooth or a baby tooth in a trauma situation? It might have gotten broken off. But if you're trying to figure out what it is, baby teeth don't have these little like mammal lines on the edges, but they're wide and flat and a little more yellow. But when you're trying to figure out like kind of ages, you may end up seeing more of this situation too. The child has got a lot of restored, they've got crowns in the back, they've got lots of fillings. And actually, I threw this in, but this is actually, these are baby teeth. This is a kid that doesn't have all those wide gaps like we were seeing on the other one. And again, girls
tend to go through these a little bit faster than the boys, not always. But that's the mixed dentition stage. Permanent teeth, and actually this is my son when he was in, not this guy, but this is my son when he was in braces. Ages 12-ish and up, again, maybe 11 and up. Permanent teeth all the way around, and braces kind of get thrown in there and can really complicate things, especially when trauma is concerned. This is Ralph. This is a guy that I saw at Cincinnati when I was in residency. This is the only child I ever saw that came to the emergency room with his own film TV crew. And you know, they say don't ever go to the emergency room in July, because what happens in July? New residents come. What is the date on this? August 12th. So I had been there since July. I had been there a month, and this guy walks in. He has braces, but you can see a little bit here. He had been at basketball camp at school, and they had like the little like bouncy like trampoline things, practicing doing dunks, jumping and doing dunks. So what happens? His braces got caught in the net. So Ralph is practicing doing dunks. His braces get caught in the net. So what happens? Pulls all of his front teeth out. So you can see they're still hanging by his braces. They're there, and it's like a can opener. They're just flipped out. So I've been there all of the month. I think I'm like hot stuff at this point until this guy walked in. And you can see it's so blurry, probably because I was shaking so much. But I had to take a picture of it, and which I'm glad I did, because now I know what the date was. But he walks in with the whole film crew because they just happened to be at his school that day, filming a story about whatever basketball camp he was at when it happened. So he rolled in with his mom, his dad. His mom actually passed out in the emergency room when I was seeing him with the film crew. So he had like 20 people roll into the emergency room. And here I am, as green can be, with this guy, trying to figure out what the heck I'm going to do. But luckily, the braces held all the teeth. They didn't like get lost along the way. They were still in his mouth. They were still wet, which is great. We'll talk about that later. And everything just tucked right back up in there. So 4 years later, when I last lost contact with him, he still had his teeth. We got him back in. We got root canals for him, and he was at least holding on to them at the last time I had any contact, knowing that he had them anyway. I don't know that I was on the news. I lost those guys and kicked them out after his mom passed out. So prevention is huge, and I don't know that you can do a lot to control those things, but at least in sports programs and schools, and in my office, I always threw out mouth guards left and right as much as you can. Who's at most risk? You know, kids with overbites. This kid was probably a huge thumb sucker, and that's why they got open bite. But when your teeth are protruding out in front of you this far, they're just begging to be broken. You know, the kids that are really active in sports and have overbite, those are the kids that we refer on to the orthodontist earlier in life. And it's an indication for early treatment sometimes. But mouth guards are really easy to incorporate. They're cheap. You can buy them over the counter. Walmart even carries them. And you can even, with braces, they make them especially for braces. You know, some sports will not let kids on the field. Lacrosse, you cannot walk on the field without a mouth guard, ideally, anyway. They should be enforcing those. You know, football is pretty good about enforcing those. I don't know, the basketball does. Some parents are just making sure their kids wear one, but those are really easy to incorporate into sports programs. My child had no fun, of course, because as you will see later, scooters. I swore I would never give my child a scooter. I did eventually give him one. There are certain things that I've seen. Trampoline and scooters are my two big no-nos in life, the most traumas. About 1/5 to 1/3 of all kids have had dental trauma by age 12, especially after school sports. Happens a lot. you may want to have an oral first aid kit. I'm sure every school has first aid kits. I don't know how many have an oral one, just for dental traumas. That may be a stretch. But, I'm sure gauze is easy to come by. 2x2s, 4x4s, I like better. I don't trust kids, and I always, even in my own office, I got really nervous sending kids away with a 2x2 in their mouth because they're so small, and I don't trust them choking and swallowing. 4x4s are kind of hard to swallow, but that's just me and my paranoia. I've just seen and had everything in the world happen, so 4x4s are a little harder to lose. Ziploc bags, you can do anything, you put anything in a Ziploc bag. Towels, washcloth, salt with a little water to clean things up is great. Spade the tooth we'll talk about later. Most ambulances, EMT crews have Saber-tooth. They're easy to get. They last for a couple of years shelf life. You can buy them on Amazon. Great to have. I always kept one in my office. And it's great for an avulsed or lost tooth. Tea bag. If you have bleeding in the mouth, black tea, wet, if you have someone bite on, will stop bleeding. And if you ever had someone in your home that had wisdom teeth taken out and you're having an issue with that, that's a great trick. If you just wet a tea bag, wrap a little gauze around it, have them bite on it, the tannins in it will actually stop bleeding. It's a great little trick for bleeding. Flashlights, you can actually see what the heck is going on in someone's mouth, because that is really hard to do in ambient lighting. Your phone in this day and age is great. Also to take pictures if you needed to send to someone's mom or onto their dentist, but also for documenting. And for me as a dentist, being on call these days got a lot easier, because in the old days we didn't have everyone in the world walking around with a phone. But now I can say, hey mom, you don't have to be the best photographer in the world. Take a photo, text it to me. Let's get an idea of what's going on before we meet at the office, or I send you somewhere else or whatever. But it's also a good way to document. I'm sure in most instances you guys probably have to do as we do. Just getting an idea, someone walks up to you bleeding, someone's fallen, and I know in my own school I've been there when our school nurse runs in and she's like, someone has fallen off the monkey bars and I have a broken arm and blah, blah, blah. Trying to figure out where we started, getting a thorough history, figuring out, is there, especially with oral things, is it a dirty wound? Do we need to follow a tetanus? Some parents may not think of that. Hopefully their physician or dentist along the way will. The cause of the accident. Head trauma goes along with oral trauma. Something a lot of times we don't really, we just look at blood and we forget that there's a whole lot more attached to that. We'll talk about that in a second a little bit more. But just kind of getting a good sense of their consciousness level, seeing what more goes with that. And remembering that it is a subset of head trauma. Concussions are about 9% of all athletic injuries in high school. So it's a pretty large subset of those. Most of you probably have far more training in these neurological assessments than me, but just kind of going through a rapid assessment of their craniofacial nerve. And their clinical history when it happened. My first question to parents is always, was there any loss of consciousness? I ask the kids, do you remember what happened to you? What day is it? Things like that. I don't know, most of you may not know what day it is. I don't know that I do. But just getting a general assessment of their level of consciousness. I have had kids, I had one that in TE ran into a brick wall, ended up having a really severe head injury from that I had to refer him to the ER because, he had really severely broken teeth, but that was the smaller part of his bigger picture. It's always one of those things, obviously this guy probably, his level of consciousness is not quite as well off as that guy. We'll talk a little bit in a minute about pins and what to look at with chin trauma, in relation to head trauma. Extraoral and interoral, kind of getting that, starting outside and working your way in. Start with the big picture, work your way in, soft tissue, and then go into hard tissue. There's a lot of stuff on this slide. You don't have to really get caught up in any of it. The one thing I want to just kind of point out is that when you're looking at head trauma and facial trauma, the most common place is the lower jaw that we see fractures. The mid-face and the maxilla is pretty stable. It's not as easy to get fractures of your upper jaw as it is the lower jaw. It moves so much. It's a hinge. It's a mobile joint, so it's a lot easier to get fractures than the upper jaw that is just a solid bony joint that doesn't move. The base of the skull. But the lower jaw is where we tend to see the most fractures. The upper, usually if it's anything, it's the nose, which makes sense. It's the most common mid-face fracture. You can see on this X-ray. I've had that myself. Signs, bleeding under the skin, laceration, swelling, bloody nose, irregular step defects, like you can see from the side for this little guy. He's got bleeding out under the nose. Hopefully this is not something that would be a common injury. This is a motor vehicle accident. He's got swelling, lacerations, he's got it all. Not a super common injury either. Most kids are super spongy. It takes a lot to get injuries that severe. Mandibular fractures, boys are affected twice as often as girls. I wonder why. My gosh, I have a boy. I know why. They do the stupid things. They are just on the move all the time. I'm sorry, boys and men, but it happens. They just get into more scrapes. Younger patients, we usually see more breaks of the condyles. The condyle is what fits into your jaw joint, into the maxilla. I've got a slide on the next one that will show you a picture of that. Adolescents, we tend to see more fractures of the angle of the jaw right here, or sometimes it's the symphysis, which is right down here. And sometimes when we have younger kids that have lots of baby teeth down here that haven't come in, it'll break around the edges of those, or you'll see them around the wisdom teeth. Like we see there, it's anywhere where there's a tooth bud down in the bone still that causes a little weak area. Causes commonly bites, and things again that are in common public places like steps, swings, monkey bars. Condylar fractures. I said we would go back to chins. Anytime you have chin tip trauma, always think about jaw fracture. You fall on your chin, it drives everything up. What happens here? This joint gets shoved up into the maxilla. Those two little joints are really, or those little bones are really thin. They get shoved up into the joint and they fracture inward. And that's what this was called a jughead view X-ray. This little guy, that little guy, you see this one kind of goes whoop, right in because there's a muscle attached. It fractures and it just pulls it in. It's really hard to see there. But that's probably the most common fracture joint we see. Also, anytime we see these traumas, fracture the back teeth is common. Again, because you've gotten this crush, you bite down, and it's easy to fracture those back teeth. So you may not see a front tooth fracture like you would see from a fall forward, but you fall on your chin, you crunch the back teeth, and those are really subtle. I saw a kid once that had fallen off his bike, and he went like 3 days with his permanent back molars on each side fractured completely in two before he told anyone he was in pain, and ended up losing both of them because he didn't want to tell anyone. It happened. This is a really old-fashioned X-ray, but again, this is what it would look like to us in the office. We took an X-ray of those condyles. Things to look for. If a child doesn't want to swallow, they're kind of guarded, holding their mouth open. Those are kind of things I look for. They can't bite together, or they close to the side. Those are kind of subtleties that you may notice. And the next slide will kind of show these things. They've got bruising, swelling under their tongue. Their teeth have a step defect, which I'll show you in the next slide again. They don't go level across anymore. Again, these are just big things that you don't want to deal with. Send them off immediately if things just aren't adding up. Again, this is step defect. Obviously, this used to be like that, and this is after the oral surgeon has done internal fixation, so things are leveled back together. This is a big sign. We see gingival tears. There's a tear through, sorry, I keep touching your screen. There's a tear through the gingiva where the jaw is broken. This is that swelling and bruising underneath the tongue. Again, these are not at all common because the bone at that age, these are all baby teeth. See the short, square, white teeth? These are all baby teeth. The jaw, the bone at that age is so soft and spongy, it's really hard to get a fracture like that. Moving on to easier stuff. Soft tissue injuries, anything you think that needs stitches, just don't mess with the dentist, send them on to the ER. Most dentists are not going to do stitches in their office. It's not a routine thing. Maybe an oral surgeon, but it's not going to be super common. Things on the face, again, that's a small one, but I wouldn't mess with your dentist, send them on to the ER. Puncture wounds like this, someone's running around with a pencil in their mouth, they fall. Those really usually don't need stitches. Obviously, you're going to send them on to get evaluated. Those are things that typically we don't need anything from. There could be foreign bodies in there that need to be removed. Seen that with toothbrushes too, because they're walking around, brushing their teeth, they fall, get a puncture wound in their soft palate. But typically those don't need too much, even though it can be kind of scary and ugly when it happens. But those are kind of easy to deal with, most soft tissue injuries. It can be kind of scary and ugly when it happens. Timing is a big deal. If it does need it, sooner obviously is more important. If something needs to be stitched up, if it goes a day, forget it. Then it's going to have to be surgically done. It's going to have to be cleaned out. Granulation tissue has started to fill in, and it's just near impossible to get a primary closure that's going to be pretty at that point. Tongues are no fun. Oh my gosh. It's very rarely that we put serum with tongues. I can't tell you how many times I've tried, and kids don't like that. They just take it right back out. By the time they're going out the door, the emergency room is gone. And luckily, tongues heal great. They can all but just heal for anything, unless it's like a flat or a really V-shaped laceration. We don't even try. And again, even under the most circumstances where I've tried, they don't do well. Injured primary teeth. For the biggest part, most kids at the age that it happens may not be that amenable to letting you do a whole lot to fix them. Sometimes it's heroic. We're either going to watch it maybe, or we're going to take it out. So if it's a baby tooth, it may be something that is going to be, something that is going to be small enough that we'll say, let's just kind of watch it, experiment, and see what happens. If it's a big deal, we may end up just taking it out. The biggest, to me, thing is protecting the permanent tooth that's underneath the baby tooth. That is the big picture. If you're 4-year-old and looked up on the edge for a couple of years, hey, that's not the end of the world. We want to protect the permanent tooth. But again, quite often we can fix it up, make it look good. That's okay. The most common things, toilets. Oh my gosh, toilets and bathtubs, kids falling off toilets. I cannot tell you how many I have seen. It is at the level of I can't even tell you. Again, scooters and trampolines. My child had no fun because I've taken care of so many of those. I think one of the saddest cases I ever saw was a little girl that fell off the toilet and hit the bathtub with her chin, and her condyles actually both fractured and they fused, and so she could not open, just barely enough to just eat. So in the ER, when I was a resident doing my
anesthesia rotation. They would take her to the operating room every few weeks and try to force her open a little bit more under anesthesia to try and open her jaw back, because her jaw had been shut. Again, it's just one of those things. Most common 2 to 4 age for trauma, baby teeth, automobiles, child abuse, seizures. Again, overjet, or you think probably in your mind overbite. Overbite is actually the up and down part. The overjet is this part out. When you've got ugly beaver teeth, they corn through a picket fence. They say that's overjet, but the overjet is what puts you at more risk. Fractures of baby teeth. If you can see blood coming from inside a tooth, that is bad. Okay, that means the nerve has been exposed. There's blood flow and nerve inside the tooth. It's going to be really sensitive. Those are the ones you probably want to say, hey, I see blood coming from inside. That's a bad thing. Here you go right now. Again, the dentist may end up just taking that tooth out. It's pretty heroic. It would take probably a baby root canal otherwise to do that, which most 4-year-olds are not going to be super happy to do unless they're put under anesthesia or sedated. But if you see something on that level of severity, and that's kind of hard to see in an emergency situation, but if it's a pretty deep fracture, you're going to hop on that pretty quick and get them out of there. Smaller chips, not super time sensitive. I mean, it's not going to have to be minutes before you get them somewhere. Clean things up, get them calmed down, call someone, it's okay. If they eat or drink something and they have a small chip and you're waiting on someone to get them, it's not a big deal. Probably not going to be that sensitive. If you can tell that they have a fracture that runs like this and goes under the gum line, that's bad. That's that tooth. Again, if it runs under the gum line, quite often there's nothing we can do to take it out because it's just impossible to restore. This is that posterior fracture we were talking about where someone gets hit in the chin and the back teeth just crunch together. Again, those are bad. Those are not going to have a successful outcome. Displacement of baby teeth. The teeth get knocked around a lot in the front. If this child is 5, this might be a loose tooth, no big deal. And sometimes that's hard to tell. And you may not want to be like super gung-ho about getting in there and wiggling it. It's okay if you do, it's all right. If it's super loose and you're thinking, oh my gosh, is it supposed to be that loose? I don't know. You kind of think, and I always, I didn't put it in the lecture, but I always had in my cabinet a little copy of the exfoliation charts of when people are supposed to lose teeth. Taped in the back of a cabinet somewhere so you could have a quick reference, because in the spur of the moment you can never think of what is supposed to be right. Teeth can be concussed, which just means it's been hit and it's bleeding around the gum. You can see a little bit here, but it's still tight. It's okay. It's not going to be too big of a deal. It can be luxated, which just means it's pushed back. That's probably the most common injury of baby teeth. Or it could be a little bit loose, which is called subluxated, which just means it's moving a little bit, but it's not pushed out of place completely. So there's a whole flurry of those things. It's not like spur of the moment, got to be emergent, got to be out of here right in a second, but you want to get them somewhere to a dentist or follow up for an x-ray. There's just a variety of things. So again, the dentist may just do nothing but watch, take an x-ray, make sure there's no fractures, and let it tighten up. Those usually will do what they do. It may turn a little dark. I always warn parents it's going to look gray, maybe, or the tooth has gotten a little blood flow that leaked out inside the tooth. Sometimes over time they look a little yellow, got scar tissue inside, but it doesn't mean the tooth is a dead issue here, and may not need any treatment at all. Worst thing that can happen is maybe a young child that's not ready to lose a tooth intrudes a tooth that gets knocked up, driven into the permanent tooth underneath. So if your permanent teeth are forming up behind all the baby teeth in place. So when you look like a monster, if you see a skull of a little child, all those teeth are sitting underneath there forming. So if this gets pushed up into the skull, it has a good chance of hitting and damaging the permanent tooth. Those are the worst injuries. Most of the time we don't do anything to those.
we watch them. The tooth will come back in on its own. The hard thing in an emergency situation, you see this happen, you don't know if the tooth got knocked out. Is it up inside? You don't know where it is. So you look around on the floor, the scene of the accident, you can't tell where it is. So always look for the tooth first. Get some light in their mouth, see if you can see anything. You know, if this is bleeding a lot, this little white thing right here may be really hard to see. Get some gauze, clean things up. Just get your best assessment to tell if the tooth is still there or not. That may be a little bit difficult, especially if you have a panic child that's really kind of, you know, difficult to calm down. Keeping everyone calm, my number one rule of thumb, which is sometimes challenging. Again, this is something that you would want to refer really quickly. But again, look for the tooth first. See, is it out or is it still there? If teeth are moving 2 at a time, 3 at a time, they're displaced several in a segment together, it's a good sign there might be a jaw fracture of the bone that the teeth are attached to. Or if they're pushed back in a segment together like this one, again, a sign that there's probably a jaw fracture. These things follow me everywhere I go. I was at the Parklands in Louisville once and found a poor kid who had wrecked his bike and all of his upper maxillary teeth were all completely pushed back into his palate, and he was sitting against a tree crying. And he was like, "I'm really messed up, aren't I?" And I was like, "Yes, you are. Let's call the emergency room and let them know you're coming." And you know, when things move in a segment together, that's a sure sign that there's probably a bony fracture. And if you're brave enough to touch it and move it, and several teeth move when you touch one, again, sure sign that there's a jaw fracture, a bony fracture. Avulsion means it is out of the mouth. Avulsion of baby teeth, we do not put them back in. I know everyone's first thing, put it in milk or put it back. If it's a baby tooth, give it to the tooth fairy. Don't waste your time. Don't let anyone pressure you to put a baby tooth back in the socket, ever, ever. It will only cause damage. It will only cause damage to the permanent tooth. And what do we want to do? Protect the permanent tooth. Number one rule. So I've had parents beg me to put permanent teeth back, or baby teeth back in, sorry. I'm not gonna do it. It will only resorb or fuse to the bone, which is gonna be a major problem. Then we have to go back and pull it back out later, and it would need a root canal to even be moderately successful. So again, when Brad Pitt's youngest, little Shiloh, who's not young anymore, knocked out her little tooth when she was little. That was the greatest thing, because I could be like, oh, even Brad Pitt's child is missing a front tooth now. You know, again, that doesn't work anymore. But at the time, it was great to have someone on People magazine missing a tooth. This is what you can see sometimes from those teeth that they've got driven in. This is hyperplasia, the yellowness, or sometimes a white spot. This one's a little hard to see because it's so bright. Those are teeth that are permanent teeth where the baby tooth had probably hit or caused trauma. You can also see that from infection, where a baby tooth had maybe an abscess that and affected the enamel, but those are usually from trauma in those instances. Permanent teeth, they're a little more fun. This is from a lecture I had for dentists, but I left it just to show you. There are some things that are super emergent, some things even for us, these could be treated later. What's the most important when someone calls you on the phone that you got to go see right now at the office? Avulsions, this is what we'll talk about, that I might ask you to touch something and get bloody later. The others, not quite as much. Fractures of permanent teeth, they come in all shapes, all sizes. There can be little bitty ones, there can be huge ones. Most don't have to be an emergency down to the minute. You just want to clean them up, get a good idea of what's going on, see if there are other things involved. Again, look at your big picture, the head traumas, the jaws, the extraoral, the soft tissues. This is one, again, that has a fracture that is running under the gum line. That's a bigger deal.
you may not be able to tell that in a situation. One of the worst traumas I saw in my school was a child in PE class that tripped over a badminton racket. He had a fracture like that ran into the gum line and ended up, we had to take this whole segment out and leave that and get a root canal, pull the tooth down with braces and restore it. So this can be really, really tricky. And you can lose the tooth completely sometimes, but if there's any way to hold on to it and restore it, we do. But those can be really tough to deal with. And that's the ones that go below the gum line, below the attachment. Again, if it's a fracture and you don't see bleeding from inside the tooth, there's not a whole lot. It can be not a to the minute thing. Again, when we're trying to decide if it's a permanent tooth, you see the mammal lines again. It's a wide, fat tooth. It's not the short, wide tooth. So permanent tooth, mammalian, yellow, wide, not the short, wide, squatty tooth like the baby tooth when you're trying to figure out what you're looking at. The nice thing with these, if you have a fracture and it looks huge like this, look for the missing part of the tooth. Look for this guy. It's probably in the grass. It's probably in the dirt. Find it. It will save this person a world of hurt in the end. Look on the floor, under the desk, because we can put them back together. See how spotty this person's enamel is? There is no way in the world that I can match that with bonding in the office. But if you bring me that piece of tooth, I can put them back together and it's going to look great. And with the stuff that we have to bond things now, those quite often will hold up really, really well. I have one of my assistant kids who actually was very similar to this. See, that's blood. He was at Bible school and fractured his tooth very similar to that and had a pulp exposure that we did a little pulp cap. We bonded him back together just like that, and he is a senior. Gosh, it happened in middle school, and he's still walking around and never had a root canal and still has the fragment bonded and is getting ready to graduate. But we can bond them back together and have a really, I mean, you can still see where the fracture was, but have a really natural looking outcome with those. And with these, it doesn't matter if it's dry. If you put it in a little water, it's not going to hurt. If you put it in a Ziploc bag with milk, it doesn't matter any way you get it to it, it's fine. But you don't have to be picky about how you get the fragment to it. I've seen it come to me in all shapes and forms and transports. It's fine. Just getting it is great. But if you keep it moist, that's fine. You can put it in some water. It's not going to hurt. But in a few minutes when we talk about teeth coming out, that is the big one I want you to remember. Nerve exposures and permanent teeth, again, if you see blood coming from inside, this is the bad one. You want to get them somewhere really fast because they're going to be in a lot of pain and it's going to need an immediate referral. I wouldn't do too much more than clean them up. And, you know, it's pretty rare if you have a fracture that bad, you're not going to have more stuff going on. You're probably going to have some bloody lips and things that go with it. It's pretty rare you fracture one tooth like that. But clean them up. Send them with some gauze or something, biting on it, and just give them some work quickly. Permanent teeth have a variety of things like baby teeth. They may get concussed, which means they get hit but not locked out of place. Subluxed again means they got hit and they're loose, but they're not moving out of place. Luxated, they're just pushed way out of place. We'll talk about that in a second. We all have little fibers that hold our teeth in place. You know, you think your teeth are stuck down in the bone like, you know, concrete, right? They're not. They move a little bit. Your teeth all have a little bit of movement naturally. And these little fibers are what these little, like, dotted lines are. That's what holds them in place. Those are important. We need those. That's what causes you to have a little bit of feeling and you know where your teeth are when you're biting. But those are the things that cause them to be healthy. Those are the things that also can cause bleeding a little bit around the gums when you have trauma. We'll talk about those a little bit in a minute too when it comes to avulsions. Permanent teeth, when they get hit, do you think this guy that got hit and has the bleeding around the gums or the one that got fractured? He does have some bleeding. We're going to pretend that that's not there. Which one of those do you think will do better?
The one that got fractured or the one that didn't? If you had to bet. The fracture, yes. Why is that?
Did you glue that together?
What? Yeah, someone. When this got hit, the blow of that fracture took all of the force away. This guy absorbed all the blow. So these little fibers underneath got more trauma on this tube than that one. The fracture takes all the force away, and typically I see the ones that fracture end up quite often doing better. It seems counterintuitive because it got broken, but we can build this back up. But this guy's the one I had to watch more because it absorbed all that force, and these little fibers don't like that. And those are the ones sometimes that will end up not doing as well, even though it can get knocked out of place. But the ones that had that bleeding and that took all that force are the ones sometimes that we have to watch for the nerve inside to do well and for the tooth to do well long term. So again, that's just neither here nor there, but my geekiness that I like to talk about. For those, again, you want to get them somewhere. You know, this guy's obviously got a lot going on. He's broken, he's bleeding, he needs stitches. You're going to get them somewhere fast. If it's just a limited thing and you don't have as much, you're going to clean them up and get them somewhere timely. Is it seconds, minutes? Not quite so much, but you're going to get them somewhere. I skipped ahead too far. This guy, you need to get him somewhere fast. You know, he's got teeth luxated out of place. This needs to be taken care of fast. The faster we can get these teeth back in place, the better, because they've been pushed out of alignment. The blood flow that goes in and out of those teeth has been cut off. So the faster we can get them back, the better for the long-term viability of those teeth. These teeth ultimately may need a root canal down the road. We don't know yet, but we will have to reposition them, and that's what we're doing here. So we have to push at the top because there's a root up there, and push at the bottom and rotate it and pop them back into place, which is really satisfying. I know it sounds creepy, but they just go and pop right back into place and lock back into place, and then we usually have to bond them with a wire or something to hold them for a week or so while they heal. But the sooner you get someone in this situation to be seen, the better. You know, they'll have to get somewhere, get x-rays, get assessed. It takes a little bit of time to get through all of that process. So the sooner we get it rolling, the better. But if you've got a whole segment, again, that's out of place, they may have a bony fracture. They may have root fractures underneath there that we can't see with our eyes that we need to deal with too.
Can I ask a question?
Yeah.
With something like this, and if this happens at school, they have to call parents.
Yes.
Is this something that we would recommend they go to the ER for, or would they be better to go to a dentist and they get
It may depend on where you live. Most ERs are not going to do squat for that. If you have an oral surgeon, they may. Most ERs are not going to have a dentist, and they're going to look at it and be like, and most physicians are not going to touch that. You know, if you're in Louisville and you're at Children's Hospital, there's a dentist and an oral surgeon on call. Yeah, and that might have an elective dentist. I would guess most areas probably would not have that.
You know, if you pay this.
Yeah, they have the residency for the pediatric residency there, so probably so. You know, if they have a dentist, they know they have a dentist, and they have, you know, regular care, and they know that might be, you know, like quick phone call, and you can go through that chain pretty quickly. And you know, their dentist may be like, I have no idea, but you may be able to trace through the phone pretty quickly. Because I would be okay with that. A lot of general dentists would feel like they were way over their head with that because they haven't treated that. You know, it depends too if they see maybe a pediatric dentist who has trauma training. Most general dentists have not dealt with that. So, you know, there's a wide variety too when it comes to your average dentist treating someone too. So it kind of leaves you hanging, honestly. And that's where, at the end of the day, an oral surgeon is always going to know what to do with this because they have been through trauma training. If you don't have anyone else at your disposal, they're probably going to know what to do.
And I think every community, at least somewhere within driving distance, probably has a oral surgeon, that is out there in the state. So that you would have at least some kind of resource. And they're gonna have the ability to put them back together with the appropriate tools too. And to clean them up, I would do a whole lot more with this person, but have them they're not gonna be able to close their mouth and they're gonna be freaked out. I can't close my mouth. Just having them close gently on the washcloth or some gauze and let them just keeping them calm, because that's what you want to do. Keep them calm and diffuse the situation, and get them somewhere. Intruded teeth, again, are bad. Even though there's not something up above that's going to be getting hit, these just don't do well. And again, in this situation, this tooth gets driven up. You don't know if it's there or not. Look for the tooth. See if you can find it. Is it on the ground? Is it inside the alveolus? Again, this is bleeding. You can't tell what's up there. Get a light. See if you can identify that the tooth is still there. These are really long and hard to treat. They have to be pulled in orthodontically. Sometimes we do it surgically. This takes a whole team of people to get back in the mouth. It is not something that happens fast. But if they fall and they land and hit just the right angle, that tooth gets driven straight up. And it is not a super uncommon trauma that can happen too. But this is one that it just takes a few minutes of scratching your head and being like, where is this tooth? And they may walk in and think, hey, I lost my tooth. They may not know. This guy, it is hanging on a wish and a prayer. And I've seen so many of these too. I've seen these from car accidents too, where it is, if they sneeze, that tooth is out of there, or teeth is out of there. This is a high risk for swallowing, aspiration, and it is like one of those, oh crap moments. Obviously this needs quick attention. I would not try to take it out. If you can keep it in its environment, it's gonna. This is like my ideal guy that has the braces, because it held them in place. It keeps it moist, and those little fibers on the tooth is keeping them in their environment so they can stay alive. If you can have them just bite on a little gauze or hold something in place, that's great. And obviously this is not a 4-year-old. This is a permanent tooth, so that you can hopefully keep them calm enough that they're not gonna lose it in the process. But that is, again, it's one of those that's really tricky, because obviously this is not gonna be a super calm kid. But it's extruded almost completely out of the socket. And there may be a bony fracture up there. That tooth may not just go right back up in there. They may bite down and it may go, look. If it does, just keep them biting down. Tell them you cannot talk. You got to just stay calm. Don't talk. Don't drink. Stay closed. Have them bite on some gauze until you can get them somewhere. Those need super fast referral somewhere. Again, this is one of those, again, that would be almost like the other one. This would almost need referral to an oral surgeon. It would probably be something that would be a little more serious than a lot of typical dentists would want to treat. This is the biggie, okay? This is the one where everyone wakes up and shakes and says, okay, I'm paying attention. If this walks into your room, this is where you get the superhero of the day. If you can do this for someone, if you're at a baseball game, if you're at a basketball game, and you can take care of this, this will change someone's life, okay? You may not think it's a life changer, but for me it is. If you can help someone in 5 minutes with this, this is where you can save their tooth, okay? If a tooth comes out, 5 minutes is ideal to get it back in place. You may not feel comfortable doing that. Any way you get it back in is better than not. If it's dirty, if you get just some dirt off and get it back in, it doesn't have to be ideal. They're going to get antibiotics to take care of the rest. Time is critical. If it's out of the mouth more than 15 minutes, the cells, those little cells that hold it in place that we were talking about, start to die, and it starts to go boom in terms of viability of the tooth. If it dries, then it's even faster in terms of dropping off. So keeping it moist is most critical. Getting it back in fast is second. So If you witness it and can get it back in, that is ideal. If you can't get it back in and I am not up for the getting it in the appropriate transport medium is second. You don't want to clean it aggressively. You don't want to get it dry, and you do not ever want to put it in water. The osmolality of water is completely inappropriate for the human body in terms of those cells. It's gonna kill the cells. So don't put it in water. Don't clean it aggressively, and don't let it get dry. Don't just throw it in something. It's better, I guess, to have the tube if everything is dead than not, but those are the big things. Out of all of these things, what do you think is the number one thing? Hank's balanced salt solution is the same as Beta tube. What do you think is the best thing to transport a tube in? Well, it's a good one. This, ideally, in research, is the best. This is what they used to put organs in. It's the same as Beta tube. Milk in research comes up as number 2, saliva 3. I don't know why you would think saliva would be number 1 because it's the most compatible with the human body. I guess in terms of research, they're looking at what is saliva may not be as easy to package maybe, and that's why in research they've used it. This preserves and nourishes the cells, and that's why it's like transport medium for organs. It's the same thing. It has a 2-year shelf life. Again, you can order it, I think, for $35. I think that's from Amazon. I've seen it cheaper online. We order it from dental supplies for about $20. If you have one in a school situation, you may never use it. That would be great. It's great also if you have a tooth come out, you can use it to clean the tooth. If it's dirty, you can dip it in there, swirl it around, pop it back into place, or you can use it to transport. This says up to 24 hours. That's not great, but I wouldn't want to do it. Milk is number 2. Every school has milk that is readily accessible. If you pop a tooth in that carton, that is great. I've had so many of those handed to me in a milk carton. It's completely fine. And again, it's easy to get. It doesn't have to stay cold. That is not a big deal as long as it is in there, but it's fine. And you can also use that to clean it. You can whip it around, get the dirt off, hold it by the crown. We'll talk about that in a second. Third, saliva. You can have them spit in a cup, spit in a Ziploc bag. If it's bloody, that's fine. There are reports of having the child hold the tooth in their cheek. I don't trust kids. I would never ask someone to do that again. I just have too many pictures of that going down. That just complicates things way too much. I suppose that could conceivably be okay, but I would never ever trust myself to do that even. How do you put it back in? Hold it by the crown. The crown, again, is the big wide part, not the pointy end. You don't want to hold it by the root because that's where all the cells live, okay? You don't want to damage those. So hold it by the crown, the wide, flat or wide side. The rounded part goes to the front. If you put it in backwards, it's okay. The dentist can turn it around when they get there. If it's in the socket backwards, it's not the end of the world. They can still flip it around. As long as you get it in the socket, it's fine. The flat is back. You remember that. It's round on the front, flat on the back. You can feel with your own tongue, the back is flat. That's the orientation of where it would go. So the round part goes toward the front, the back is flat. This has already had all the compression, all the damage, the nerve has been severed. It's not going to hurt them to put that back in there. I know it sounds excruciating. Yeah.
Going back to the bill,
Mm-hmm.
does it have to be cow? No. Not the bill.
I have never seen that in any research.
It's not much.
It's a good question. I don't know. I will have to Google that myself. I've never seen it.
You've asked me a good question. 20 years ago, we didn't have almond milk everywhere. Interesting. Now I'm gonna lay away tonight. I've got to find an answer. And if I find it, I will let her know. So, oh, that's gonna drive me nuts. I would guess, I have seen the chocolate question come up and I don't remember the answer. I don't know. I'll look. Don't aggressively clean it. Again, you can dip it in there, swirl it around, get the big particles off. It doesn't have to be perfect. If you can get it in, just slide it back in. It may not go in all the way. If you get it in a little bit and have it bite down, it's better than nothing. There could be bony damage up there that will keep it from going in all the way. If it's in somewhat and they bite down on something to hold it and it seems stable, that's okay. You have to, again, keep them calm, no talking. This is the time you gotta keep it in and not talk. And you can see you're gonna get quite a bit of blood back out, especially, blood clots in a normal kid start to form really quickly, and it's kind of messy and it's ugly and it's gonna look like a bloodbath when it happens. And that's just kind of part of what happens. It's gonna bleed a lot anyway. The mouth bleeds like crazy when injuries happen. And everyone freaks out when their tooth comes out. It is not a pleasant situation. And you can see this is in the office. This kid is on nitrous. He has laughing gas. So again, it's been a while and it's clotted. This might even actually be a case where the child came the next day. I think there was one that we put in the next day that I filmed. Once it's in, and we see them. Oh, this is the operating room, I'm sorry. Because he has stitches. Once we get it back in, we're gonna keep it back in with either wire. Sometimes we use fishing wire, or fishing line, which is actually awesome. It's a little bit flexible. We'll bond it with something. And most of those end up having a root canal, and we'll have the root canal started before we take this off. We'll leave that for about a week or 7 to 14 days sometimes before we take it off. The body heals amazingly fast. It's crazy that you can have a tooth completely out of the body and in a week it's can be held back in. And it's really, really, really amazing. And again, over 2 million teeth in the United States a year are knocked out. It's gonna happen. Everyone in this room has a really high chance that you're going to be around someone who loses permanent teeth. Especially, again, if you go to any sporting event, it's going to happen. I'm a glutton for punishment. Anytime I'm anywhere, I'm waiting for my chance, and I still haven't had it. I've had it in my office, but not in I was at soccer 2 weeks ago, and there was a kid bleeding running to the sidelines, and I was like, this is it, this is my moment. And it was no, and I was like, oh, not that I wanted him to have his tooth knocked out. But I was like, the coach, I used to see his daughter, he knows who I am, he's gonna come get me, this is it. And I'm like, okay, it was just funny, man. What happens when you don't get follow-up? Things don't go well. This is a child I saw that I didn't take care of, but they said they didn't know they were supposed to go back and get follow-up. They had a tooth replanted, and this girl had she was beautiful. She had such beautiful teeth. Her tooth, this was replanted. She never had anything done, and the body completely resorbed the tooth. This was all that was left, and it was just pain flowing. So we took it out and gave her her temporary was a little retainer with the tooth on it, which was not gorgeous, but to get her by until she could get something else. Again, the body has a way of taking care of things, and it just completely dissolved the tooth. But most of the time, if it's a very young person and the roots, your teeth grow from this end to the end of the root. That's how they develop. If you're really young and the roots haven't completely formed, sometimes they don't need a root canal. I don't know that I've ever really seen that happen. Most of the time you need a root canal. Prevention, car seats, seat belts. in sports, all the things that we have to wear, you know, all held mouth guards. This child has a 15 millimeter overjet, obviously, and you can see there, when they fight together, their bottom teeth are hitting their mouth. They have a severe overjet. That is someone who's really, they are a great candidate for early orthodontic intervention. You know, a lot of orthodontists are kind of conservative. They don't love to jump into those, but I was always pushing, you need to go earlier. You're very active. You're high risk for trauma. Sometimes we can start with early treatment versus not. You know, I wrap everyone in bubble wrap. What's this? I just saw this week and threw it in. I thought it was a great one. Can anyone tell me what this is? No? This is totally unrelated, but I can do this because you might see this. It looks awful. It looks like her face is falling off, right? And this is one that walked in. This freaks physicians out. They would put this kid on antibiotics, an heartbeat most of them. And it's kind of bright, kind of hard to see. Yeah. Kids who are numb, who have been to the dentist, chew up their face all the time. And it looks awful afterwards, awful. And they feel great. I always try to prepare everyone. And, you know, sometimes before they get out of the chair, they've already started this. And, you know, quite often we give them a piece of gauze sticking out, you know, to try and keep them from doing it. But when it starts to heal, you know, it looks fresh, it looks like this, but as it starts to heal, it gets like scabbed over and it's big, thick, ugly. And where it stays wet, that's how your mouth heals. It gets that yellow scab. The dry part is not going to look like that, but the wet part is going to have that yellowy, thick, boggy look. And it just freaks people out so much. And then we'll throw people on antibiotics every time when they see this, the face is infected. It will heal great. You don't have to do anything with that, but it honestly looks so bad. It looks like, you know, there's lupus going to fall off. You don't have to do anything with that, but keep it moist. But, you know, you can have that walk in so easily in a school environment. You know, the next day they walk in and you think, oh my gosh, they got like some serious like disease or something. They just need, if they would spicy things for a few days and keep some Aquaphor in it, because Aquaphor makes everything better. But I just saw that this week. I thought it was such a good one to throw in. But such an easy one. Oh, I love that slide on the left one, and I skipped it. That little guy, one of my friends from Louisville gave me, was a kid that fell out of his mom's car. This was like obviously this was like from the 70s or something. I don't know. My friend gave me this. He fell out of his mom's car on Bardstown Road at the Kroger, like back when there were no like seatbelts and things that were used, and got all beat up or anything. Obviously, he had no fractures or anything. He looked like a little raccoon. He's so cute and happy. That's it. Questions besides the almond milk, and I'm going to look for that. Thank you for having me.
So would it be hard for you to do just this mini cheat sheet? I'm thinking about sitting in my clinic in the nurse office, and it said, loose baby tooth to nothing, blood inside the tooth, immediate referral, permanent tooth loose, da, da, da. And the other thing is if the accident happens at school and we fill out the paperwork, so the school's insurance, see, I'm worried about how they're going to pay for it, and do we send it to an oral surgeon? I mean, that's easy to say, but I can just see myself calling and saying, they don't have a dent. Okay,
Right.
So what's the next call? And do they have appointments open? Do they?
You got to send them somewhere.
Yeah, so is it best to send them to a pediatric ER where they've got those kind of dentists, or? I mean, I'm just trying to think the practical spending part.
Right. If there's a pediatric dentist in the community, if there's an oral surgeon in the community, if there's general dentists in the community,
That's the way to go.
you know, those
The
would
oral
be like,
surgeons, do they always take care of kids?
not always,
Yeah.
but, you know, again, they have the training.
It's just, we get them and then we immediately got to decide.
Right.
Do
We
it.
got to do it fast, right?
And where
Right.
it's then.
Right, exactly. And you're right, they may never have seen anyone. They may not have.
Most likely.
Right, exactly, especially depending on where you're located. Absolutely. For sure.
This was very informative.
Oh, thank you so much, I appreciate it.
And if you guys have questions later on, you can always email me and I'll get them to her. So,
Anytime.
Great. Well, thank you.
Thank you, I appreciate it.
Okay, we are gonna hop right into our next session. I told you we had lots of stuff going on today.
After Dr. Hansford's presentation, Megan and I were sitting back there, she has little ones. She said she's not allowing her boys to move anymore. And I have grown daughters. I guess granted, several years down the road, like there, but wow, that was an amazing presentation. My name is Janae Sutton. I'm from Hardin County Schools. This starts my 27th year in education. I've been a classroom teacher, assistant principal, guidance counselor, and I'm now the director of health and family services. I have completed 10 years, so this is my 11th year in my position at the district office and student services department. I work very closely with a lot of different groups of folks in my school district just to get a little better understanding where I'm coming from. I'm the Family Resource Youth Service Center district contact. All mental health counselors, whether they are employees of us or we can contract with them through Cumberland. And then we have several that contract with our school district. We have about 10 different contracts that we manage from the community for school-based therapy. Work with anything basically that is needed to eliminate non-cognitive barriers so that kids can learn. So a lot of mental health, physical health, any type of needs that they in order to be successful with their academic careers. And then just Megan.
Hello, I'm Megan McMillan. I'm the Chief Nursing Officer for Cumberland Family Medical Centers. I've been with Cumberland for 13 years. We started our first school-based health center in 2014, and the district health coordinator, Patty, is here. We started telehealth for the first time at that time. And so, Patty, I may be asking for your feedback because we've come a long way, and Patty will attest to that. So I'm happy to be here today, and we're going to let Janae go ahead and get started. We just want to talk to you today about collaborating with the school and either a medical entity or another health type entity to be able to offer telehealth to your students. We feel like it's a huge benefit, and we do telehealth in all of our school districts that we coordinate with and that we partner with. So we want to give you all more information about that in case you want to discuss that with your partners, your medical partners, or if you want to look into doing it on your own or finding a partner to do that with.
Robert Sprang, he is the director of telehealth and telehealth type services through University of Kentucky, and they were doing a telehealth summit back in June, and he had heard about Cumberland and their partnership with schools and so forth, and just kind of wanted to reach out to discuss because a lot of us in our personal experience, we might have used telehealth. I'm going to celebrate half a century. And so you start doing things that I'm used to, going in, sitting down at my doctor's office. It was an adjustment for me to get used to seeing a nurse practitioner as opposed to seeing a doctor. And now we're not just going to see them, but we're also going to go across the TV and so forth. So some of us have personal experience with telehealth, but bridging that and helping our parents in schools and so forth understand that can be very beneficial to kids. So that's kind of where Megan and I started with Robert Sprang. So as far as school health in our school district, and it's probably very similar to your school district, we had a very tight partnership with our local district health department. We love our Lincoln Trail District Health Department. They've always been wonderful. When I came into this job, learned a whole lot. The school nurse team that was with us at the time, we only had one HR. We had 3 high schools in our district. Each one of those had their own school nurse.
But then the rest of our schools, we have over 21 schools, shared 3 to 4 school nurses. And their only purpose was to help special health care needs, whether it was seizure activity, diabetic care, G2 feedings, and things like that. That was their main focus, as well as training our staff so that they could be UAPs within the district and as far as like medication administration and so forth. So we were there, I guess that for my 10 years in the school district, we started there for the first few years, and we only had a few special needs nurses. So then it expanded. The health department came into some funding for school health, and they provided a school nurse at every one of our schools. And for those of you that are sitting in that position, you know how wonderful it is. But then when the funding leaves and you attempt to tell folks that we're going to go back to the way, that's not going to happen. So, and it didn't happen. So unfortunately, as they're governed by the Department of Public Health and so forth, I'm not sure what all went on with funding. Our local health department made a choice to reallocate, and they informed us of May of the school year, school nurse funding is gone. So our school district took a step back. They have recruited some wonderful school nurses who agreed to stay with us, and our school district became their employer. And that seems like situation solved. They just have a different employer. Well, situation was not solved because then you do not have a medical director. And for many of our parents, we have over 15,000 students. They depend heavily on administration of those OTCs, your Tylenols, Neosporin, when you have all those cuts. If you don't have a medical director, you don't have that. So for that year and a half, we managed and did things a little differently until Cumberland Family Medical. They have been with us, and the year that they started with us was in January of 2020. We all know what happened in March of 2020. So why Cumberland Family Medical? We had an established need. Obviously, we had no idea what was getting ready to come through door number 3 in March, late February, March of 2020. Well, we couldn't be more thankful that they bridged that with us. So other school districts had a successful partnership. LaRue County, Dare, anybody you called and talked to, it was just a good way to go. We met with their chief medical officer, Dr. Eric Lloyd. If you've ever had the pleasure of meeting that gentleman, he has a passion for kids and a passion for them being healthy. And so his right hand for school health is Kitty Hopper, and that's who we continue to work with and so forth. So great leadership, great mission. Their services, they have, we've expanded with them, not just school nurse, we have mental health services, dental. They also have that they have brought in. But today we're going to focus on the Healthy Kids Clinic and what we've seen as a result of using telehealth. And I know that so many of us here, and it's very easy to catch into the negativity of what happened during the pandemic. The word pandemic is a negative word in itself. But how many wonderful things have resulted and come out of that, ways of thinking differently. We were forced to think differently. And telehealth, the expansion of it was already there, but the expansion of it is what we would like to reflect on. So we have here students are assessed and treated in a timely fashion, thus reducing hospitalization. With those kiddos that have diabetic needs and seizure activity, when you have that regular relationship going on with your school nurse, we of course have those permissions to speak to their general practitioners, to their specialists and so forth, and they can report things back. Kids, especially those that get diagnosed with diabetes, that late elementary, middle school, their bodies are changing so much. So that is a crucial partnership that has definitely been forged there to help those kids to avoid those hospitalizations. Parents that can't leave work. In Hardin County, we are heavy industry. And I don't know how many factories and industries you have, but folks can't be absent. If they are absent after X amount of time, then they could potentially lose their positions. So our industry folks that send their kiddos that are part of our schools. And then also the other thing is we employ 2,500 staff members. I don't know about you, but it's hard to find a teacher, much less a substitute teacher. So it's really, really nice. The telehealth services, the parents can give permission. So as far as permissions are concerned, you have permission to see the school nurse And even if the parent at the beginning of the school year on paperwork checks that they have permission to see that our practitioner or provider, they still call, because you want the parent to be fully informed what's going on with the child. Just reiterating, you've given signed permission. Yes, the nurse practitioner or the provider cannot get to our school. Are you okay with telehealth services? You're welcome to come sit with your child. You're welcome to just wait, and we'll call back and let you know different things that are going on. So it helps parents not have to leave work if they can. Absenteeism, I work really closely. I think somebody raised their hand on the DPP in the school. I work with risk and DPPs. We know that attendance is obviously directly related to how much a kid's going to learn in school. But there are so many conditions, some sinus episodes and things like that. Telehealth visit, prescription, parent can pick it up on their way home from work. Child never even has to leave the school building. Therefore, your seat funding is not affected because your attendance is not affected as well. Another thing from the school perspective is keeping, this was crucial when we partnered with Cumberland Family Medical. They had only been in school districts that were extremely rural. And for those of you that have ever traveled through Hardin County, we're extremely large. We have half of our county that is rural, but half of our county that's pretty much saturated. And they really had to talk with us and so forth, because we are very blessed with Baptist Health, with their whole, I would say, army of doctors and physicians and specialists in Elizabethtown, and also other primary care providers and so forth. So when you look at that, we had, at the time, it was Hardin Memorial and some other partners, you know, with Cumberland coming in, and how's this going to work? But they are very eager when you have a telehealth visit or in-person visit. They send notes back to them. I know ear infections, strep throat, instances of all those tonsillitis and things like that. Those are key for a primary care physician to know about, to see if some other steps need to be taken with that child. Because sometimes if you're just being at school, if there was not that communication and that relationship going on, and then they go, you know, summertime and they have, you know, 2 or 3 more ear infections, and the provider and school sees them, if they're not communicating, then they're not going to have that good medical history there with the kids. The other factor, like I said, some of us, a portion of our county is very rural, and transportation is an issue. They can't get it. I mean, you say, just take the kids to the doctor. Well, I don't have gas to go get food, much less to go there. And the socioeconomics, you know, a lot of low socioeconomic families, they don't realize the importance of regular physicals and different things like that. So these telehealth visits, a lot of times, unfortunately, in 2022, we realize that a parent, they'll say yes, just as long as they don't have to do something. So, okay, you want to see my kid? That's great. The key and the point that we have here today is that the kids are getting the health care that they need in this different fashion. Mental health services are also offered. I shared that they do have a mental health division. Of course, we want those interactions to be face-to-face, and the majority of the time, they're always face-to-face. But again, your intake meetings, how many times have you known a kid needed school-based therapy and couldn't start because we just can't have the intake meeting because we can't get the parents here? So those, that can be done through telehealth. A visit, if something got canceled suddenly and you couldn't get a rescheduling, that can also be done through telehealth. Also, we're entering flu season and all that stuff, so contagious diseases, especially with our little ones, those high schoolers traveling around in hallways together. If we can catch a case and we can get that student and get them diagnosed and know that's what that is, and get them home to where they can recover until they are out of that contagious period, then that's going to again help with spreading of the disease as well as attendance and so forth. Like I said, healthy children are successful children. And Megan is going to touch in more specifically how when their providers are working, it's called a Healthy Kids Clinic. That's all of our school nurse clinics within each of our buildings, and how it specifically happens with my building.
Okay, thank you, Janae. As Janae said, we do offer, well, let me just give you a little background first of all. Like I said, I'm the chief nursing officer. We started school-based health similarly as Hardin County did back in 2014 with Russell County Schools. Similar situation. They had health department funding that had been cut, and that would have eliminated some of the school nurse positions, or would have eliminated some of the ability to be able to have those in every building. And so we partnered with them at that time just because we saw an opportunity. We see and we value how much school nurses do in the schools for the students, not just necessarily for the students with those chronic conditions, but also for those students with acute care needs. So we really wanted to make sure that there was a school nurse in each building, but then we also wanted to make sure that kids who don't necessarily have those opportunities to go to a primary care physician, or maybe the parents just can't take them for some reason. We wanted them to still have the same opportunity to be able to get services. And so in addition to the school nurses, we offered a medical provider, a nurse practitioner, who would rotate through the schools, seeing those students for those type of visits, whether it be a wellness visit, if it is a preventative, acute care, chronic condition. We wanted to be able to offer all of those services that you could get in a PCP office. Definitely not replacing a primary care center or a medical home, because that's incredibly important, but we also know that there are barriers to doing that, and many parents can't take their children to the doctor. So we didn't want to replace that, but we wanted to be there for students who needed us. Thank you. So this is a little small. I do apologize. Hopefully you all can see this. I know on the screen it's a little small for those who are watching remotely. Oh, perfect. One challenge that we found, though, with having a nurse practitioner rotate through the schools is the school day is a little shorter. You have bus routes, you have different challenges to getting all the students seen in a shorter day period. There's some school districts have everybody kind of on one campus, and some school districts have schools over 20 miles, 30 miles away. So that also creates challenges in our nurse practitioners getting to every location in a set period of time. And it was a concern that we didn't want children not to get services if the parent or the student needed that. That's when we implemented telehealth. To give you some background on that, and Patty is here, and she can tell you it was a rocky start. 2014 technology is not where it is today. We had very large carts in very small nursing stations, and if you all, I know all of you all have been in nursing stations. Some of them are large, and sometimes that we get lucky and we get a whole classroom, but sometimes we get a very small little closet. And so these carts were huge, and they took up too much space that those nurses need to be able to assess those children. There was lots of screens and lots of wires. Broadband internet in 2014, we've come a long way. It was not quite where it is today. So there was a lot of pixelation of the visual images, distortion of the audio images. It just wasn't user friendly. So it's hard to get buy-in from your school nurses to do telehealth when it's difficult and it's hard, and they're already trying to take care of all these kids, and they might have a lot of 5 or 6 kids waiting to get their routine meds or to get an over-the-counter med. But if the nurse is trying to facilitate a telehealth visit for a student, you're not going to get that buy-in, nor should the nurses be expected to have to do that. So for a period of time, we just kind of stopped telehealth. Luckily, we found some new technology back in 2020, which was, of course, right before the pandemic, which worked out actually very well. Not that we knew that was all going to happen, but it did really enforce the need for telehealth. Now our telehealth equipment is very small. It's a laptop size. It sits on a little, and I do apologize. I was going to do a demonstration today. Went to get it from my office this morning. Our IT staff had taken it to a school that needed it. So if anyone is interested in seeing it, though, my contact information is on the last slide. I have some cards here. I'd be happy to set up a demo for anybody who wants to see what equipment we use. We use Tydo, which is the type we use, but there are all different kinds of telehealth equipment that you can use. Very small, like I said, laptop size, sits on a small little drawer that you can open and keep all your devices inside. There's not a bunch of wires. Of course, internet has improved, and you all have probably seen that in your own practice in your own schools. You've probably seen your internet faster. So now that internet and broadband has improved, the picture is more clear. It's got a more clear audio, and it's also more user friendly. So it's not a huge burden to your nurses to utilize to help facilitate those visits. For the collaboration, and I feel like that's really the most important part of this whole process, is you have to have a good collaboration between the medical partner and the school district. If you are a school and you have currently a medical partner you work with, you can talk to them about the ability to do telehealth, but there's also different platforms out there to do telehealth as well that you could look into that do it more on a nationwide basis. But implementation is the key part. You have to have your IT involved, and you have to have both ITs involved. You have to have whoever your partner's IT is, and you have to have the school IT, and they have to be on the same page to communicate. The schools have a very secure, very private network. So you have to make sure that your IT knows what this medical partner would like to do, and make sure that it's feasible, make sure that it's allowable. You need to work on workflow development, and that's probably where your district health coordinator is going to come in and help work with those nurses and figure out how to make those visits flow. Because we don't want to interrupt the nurses' day in doing those routine medications and doing the things that they need to do for those students to facilitate these visits. It has to be a smooth workflow. And communication is very important. From the beginning to the end of the process, you need to be able to communicate with each other what's working and what's not working. Telehealth education. When we first started in 2020, telehealth was still not really well known. Not amongst a lot of our school staff, not amongst a lot of our communities, not amongst our parents, not amongst our students. And so what we found, though, is that your schools are the central hub of communication in your district. Generally, that's where a lot of communication comes out as far as even community events, local happenings in your community. And so using the school as that hub of communication to communicate about telehealth was key for us. We could tell parents, this is secure, this is safe, this is HIPAA compliant. But we really needed the schools to communicate that as well as our partners. They were able to get that information out through all calls or through notices that they emailed out to parents or staff. And then also just informing parents of the telehealth process, how it works, who it's supplied by, that it's a trusted partner. Here's what it's going to look like. It's going to look like you're going to get a call and they're going to ask you if you want your student to be seen. And if you do want your student to be seen, then this is how this visit is going to work. The nurse is going to facilitate that visit. A provider is going to be able to do all of these things. They're going to be able to see in your child's ear. They're going to be able to see down your child's throat. They're going to be able to listen to their breath sounds. They're going to be able to listen to their bowel sounds and their lung sounds and their heart sounds. And it's going to be very similar to a visit. And then after they're finished, then they're going to call you and they're going to tell you everything that they saw, everything they heard, what their diagnosis is, and what their treatment plan is. So making sure that parents know that this is going to work very similar to an actual visit. Telehealth may be concerning for some individuals, mainly just because of the knowledge deficit. So the schools being able to communicate that safety and security, knowing that their protected health information is still protected, that the network that we utilize is secure, I think that's important. Clinic staff communicate with parents after, so prior to the visit and after the visit is key as well. Making sure the parents understand the whole entire process. Collaboration of IT, I mentioned this earlier, but that is incredibly important, that IT discussions start very early prior to implementation. You want to make sure your school and your clinical partner IT are on the same page, that they know what each other is accessing. We want to make sure we determine that the internet access is there. There's some schools that we work with that we cannot get internet access, for whatever reason. It could be because there is it's in an area, because we utilize wireless. We utilize wireless network. And so it could be that the signal's not strong enough. So working through some of those challenges. And then testing the equipment. It's the worst thing in the world when you have a kid who's truly sick and needs to be seen, and you've not tested the equipment and it doesn't work, and you know that provider can't get there in time. So just making sure that you're testing the equipment prior to implementing it, having IT from the clinical partner go by and test it frequently, especially after breaks. Sometimes they clean the floors during breaks and things get unplugged. And so during those times, making sure after those breaks, those IT staff are coming back in, making sure everything's still working. And then just ongoing communication. Very important that there's ongoing communication with both the clinical partner and with your school district. And then just the focus needs to be on the outcomes for both the school and for the clinical partner. We want to make sure that we're improving access to care, removing barriers. So as Janae mentioned, there are rural areas with less access to health care. Many times parents work. They can't, be there to take their children to their normal PCP, so we can stand in for that. Then there are some parents who maybe just don't have transportation or don't have money for the gas to take their car to take their children to a visit. And then providing that high-quality care visit with the enhanced technology. I think we're all very familiar now with Teams and with Zoom and with Google Meets and how you've got that kind of face-to-face interaction and we can talk to each other. But if you are able to find a partner who has the enhanced technology with something similar to Tydo, then you would have the ability for that provider to have a more comprehensive visit, They can look in the ears. And it's amazing if you ever see the images, how great the images are that the provider's able to see that nurse facilitates that visit. They can look in the throat. They can listen to their heart sounds and their lung sounds. There's our rest of our information. Sorry. Oh, that's okay. And then, as Janai mentioned, more time with classrooms and learning. And that's important. You know, if a student has flu, or if they have COVID, or if they have strep, or a communicable disease, if we test those students and they're deemed that they need to go home, they need to go home. But as you all know, sometimes it's allergies, sometimes it's sinuses, sometimes it's an ear infection, and maybe it's, it's not hurting so bad that they can't participate in class. Students are going to be better students when they're healthy. So if we can make sure that we have a great partnership so we can keep the kids healthy, because they're going to be great students for you guys. The last slide is just our contact information. Like I said, I do apologize I wasn't able to bring a device today for the demo for you all. But if you're ever interested in seeing what ours looks like and what our process looks like, I'd be happy to share that with you. My contact information is here. Also, Janae can talk to you from a district standpoint about how it looks for the district and how it works for them, to give you that type of feedback or information there as well.
We have a wonderful team of school nurses. I would argue any day that school nurses are equally valuable in the school atmosphere as our classroom teachers are. And any of those school nurses, like if you have somebody in your district that you're looking at, you would like for an elementary nurse to talk to one of our elementary nurses. My information's there, and we definitely love to connect you guys.
So how do you go about the consent? Do you like combine both your consents, or the school has consents and then you have consent?
Beginning of school year, we have Cumberland Family Medical, and anybody can go on the Hart County Schools website and go to the health, and you can see what they look like. And they fill out primary care physician. They fill out, all, like, they do a kind of like a little HP history and all that kind of stuff. And then they no services. So they don't allow any, no consent, it's no consent. However, what I will tell you is kids will come down, and then parents, they're at work and they're like, hey, I give verbal consent, and I think 1 to 2 times they would allow something like that. Or I just want school nurse services. If I want school nurse services, then I allow, we have the ROTCs on there. I want all services to include a nurse practitioner visit. And again, we still always call our parents to say, hey, we're looking at them. They got white patches on their throat. Looks like it might be strep. Would you like to go ahead, or do you want to pick your child up and take them to a primary care physician?
So
it's
Cumberland, with teaming with Cumberland Family Medical, so they don't have to fill out like HIPAA or.
It's all on
It's all on
the
Oh, okay, it's all, okay.
Yeah. But now we do tell the parent prior when we call. If we know the provider can get there in person, or they're going to already be at that school, then we say the provider's going to be here, you can see them in person. If the provider is not scheduled to be in the school that day, or we know they're scheduled full and they can't specifically make it to that school, even if we have consent on file for telehealth visits, we still telehealth, just because there is still parents who might be hesitant to do that. So we do make sure they know this is a telehealth visit, as opposed to that in-person visit.
So the parents don't get aggravated that they have all these paperwork to fill. I mean, I'm just asking from a. We have that problem.
Yeah, and I would say almost the biggest thing to avoid, like we have a high school that's 2,000 students, so that school nurse, she has to scan in, and that's, on Infinite Campus and everything. But no, the parents fill out that one, and that's their consent for school nurse services. School nurse. Otherwise,
We're one of her newer districts in McCleary County, and I'll just tell you, it has been seamless this year. We went from a primary care, like just regular physician's office that was doing services through us, to Cumberland Family, and it has been seamless. We've had no parent complaints. We just completed our flu clinics last week at all of our schools. That was seamless, scheduled, and so I hold you guys in high regard, and I just wanted to say that. So.
And I will say, you have to have consent for the kid to come and see the school nurse anyway. So this form just takes the place of what we had a separate form anyway, so it just took the place of that form.
we control traffic in our Healthy Kids Clinic with a Google form. So every teacher I've created and I created it, and then our IT guys pushed it out. And it's like, first name, last name, classroom they're in, the phone extension and so forth, and chief complaint or whatever. And so the school nurses can control their traffic. It's not, oh, honey, you're sick, go on down. Oh, honey, you're sick, go on down. They literally have, then it feeds to a Google sheet, and that school nurse is in control of that Google sheet. And we're vomiting or bleeding, we come on down.
Right.
But, if we just have a headache, and they kind of triage, it's a little bit of a triage piece to it as well.
That would be awesome.
Mhm. Plus, if it's the same kid that has a headache.
Every day.
single day.
What do you have?
It's-
And I'm real proud of the board. We do take into consideration feedback from you all. So every year, we try to say, and from parents, because we have multiple staff members who have kids in our school district, and we'll ask, what didn't work on these forms? What confused you? What was good on these forms? What was bad? And we pretty much change our forms. I mean, you've been through how many forms years? 8 years of forms now, 9 years of forms, and we probably change them a little bit every year, just because what we do find is that, for instance, school shots. We just finished school shot clinic. Last year, we had parents fill out the flu shot consent and then say, well, they didn't know what they were filling out. So we put a big bold thing on the top. Do not fill this out if you do not want your child to have a flu shot. Now, this year, we had that happen less. We still had it happen. So now we're like, well, do we put it in red? Or do we put stars on it? How do we really get parents? Because I do realize that, yes, you're right. Parents, that's a lot. Because they're not only is it our forms, but it's also your forms that you need to fill out. So like Katie said, the good thing is we can combine at least that part, and we do try to keep it as minimal as we can, although there is more information we would ask than you all would necessarily ask just for your school nurse services. But it definitely, we do take into consideration feedback because we want it to be easy for parents. So we want them to fill it out, even if they don't necessarily want services, we still want them to fill it out so we know either way. We need to know when that student comes up. Can we provide services or can we not?
Or do they have because our school nurses document and I see, of course, all conditions. So you might say no consent, but you want that health condition that's known, that child's an asthmatic or, whatever.
Billing. So our school system doesn't do billing for our nursing services. It just has never been a good situation for us. But for billing for you guys, if you tell health, would they turn in their insurance information as part of that consent?
They do.
It's already on there.
Okay.
So I have a question. I wanted to thank, I worked with Eddie. My name's Michelle Malcolm, School Health Branch Manager. So we've met around that. But I had just a couple of questions. So when they do the testing, like the flu test, the nurse is actually doing the test. And then she holds it up to the camera and she says, here, okay. So that was the first question that I had. You all carry the clear.
We do, yes.
Okay. Who employs the nurses? Do you pay the nurses? Are they your employees? Do they work at the school district?
It depends on the district. So we work with the district. If you have a district who has some school nurses who've been in school nursing at that district for a long time, they feel that retirement and all that. So we definitely don't want to.
For their retirement.
Yes, we don't want to hurt that. So it's a discussion. We're more than willing to try to do what works best for those school nurses because we want it to be a good transition once we establish that partnership.
And then how much does it cost for one telehealth visit?
Depends. I don't do our billing, and so I couldn't tell you an exact amount, but it would be depending on.
They have insurance, and they were
Right, so we, as a federal, so it would depend on your medical partner. Now, we are a community health center or a federally qualified health center, so we are able to offer, because we get some
on the
federal
sliding
grants.
scale.
Yes, we're able to offer sliding scale if they don't have insurance. If they have insurance, then it kind of depends on the insurance. And as far as the actual price that we would bill, that depends on the type and level of the visit, of course, with the provider document. But yes, we do have sliding scale. So we also have a hardship policy, so even if someone qualifies for sliding scale, but they still can't do that, we have a hardship policy that we can go through. So, we never want to be a barrier for care. Our goal is that anybody who wants care can receive care.
Thank you.
You're welcome.
Did you touch on the cost of the equipment?
I did not. That's a good question. So, equipment can be costly. I'll be the first to tell you that whether it be you're going to do iPads with a Zoom to facilitate a visit, or if you're going to do something like Tato, it can be costly. So what we did initially was we started looking at grants. So started looking at grants. Now I think there's possibly grants out there through education as well. So we started looking at what grants can we apply for that would allow us to get the equipment so that we could facilitate these visits, because we do have a lot of schools. If you have a district and you're looking at purchasing them for just your district and you maybe have 5 or 6 schools, it might not be cost prohibitive. It may be something you could do, or it may be something your medical partner could do, or there could be some type of mutual agreement for that. But we wanted to be able to offer it to all of our schools, which I think we have 119 schools that we actually partner with right now. So that could get very, very costly. So we started looking at grant opportunities, and there are grant opportunities out there very specific for telehealth. It's kind of a buzzword right now. So if you kind of start looking at that, you might be able to find those grant opportunities, not only as your medical partner, but actually as a district, you could possibly find those opportunities as well.
But how much is it?
These units, I'm thinking it's been a while since we looked at them. I think they're around $3,000 each.
You say 3 or 30?
3.
But if the district purchases the equipment, would your IT people, they maintain it, they do the maintenance, they pay? Oh,
Yeah, we purchased all of our units. But, you know, once again, it kind of goes back to what type of collaborative agreement you have with your
Yeah.
district. We have a collaborative agreement that allows us to be able to share information, you know, always with permission, because, you know, it's a very valuable network that the Kentucky Department of Education has in the schools. And so we want to make sure that we have permission for that. So it may be that even the IT staff in the school district would need to go to the IT staff at the KDE level to ask for permission, which is what the route we've went in the past, which has worked for them.
Because some districts have medical Wi-Fi for the diabetes apps and things like that, because
Yes.
they have experienced some
Yeah,
issues.
and we do have, you know, depending on who your medical partner is, we have these, they call them towers. It looks, I wish I had one with me, but it's about this tall, and it's like a MiFi, only it's a larger MiFi, has a much better signal, so that's what we use. And then sometimes if we have a good signal, we can use the smaller MiFi to be able to do that. So, you know, it just goes with the school district. So the school district has that network, a separate network we can utilize, we can do that, but otherwise we have MiFi we can utilize as well. Any other questions? Thank you all so much, and our contact information is on here. Also, if anybody needs a card, I have a key card.
Okay, Kim has an answer for you about the oat milk, so I'm gonna let her come and tell you.
So quick answer to your oat milk. There are studies looking at soy milk. I didn't find oat milk, almond milk, even coconut water as a substitute. Anything is better than water or letting it dry. Soy milk, almond milk have been studied, coconut water, and suggested that they might be decent substitutes. There are no large studies, but again, anything's better than nothing.
Okay, it is 12:15. We are going to break for lunch. We will come back at 1:40. Welcome back everyone to our afternoon session of the 2022 District Health Coordinator Conference. I am going to turn this over to Michelle Malico with the Department of Public Health, and she's got a very informative session to share with you, and I'll turn things over to her. Where do we? Yeah.
So, good afternoon, everybody. I did want to, before we start, go around the room and we can tell me who you all are, because a lot of you I've probably spoken to. And I wanted to put face to the name. So if you'll just tell me what your name is and where you're from, I would love that. So how about everything? Okay, all right.
Becky Swan, Danville Independent Schools, Danville, Kentucky.
Okay, all right. And just wanted to how to get me?
Sherry Curtis, Fayette County Schools.
Okay, and that,
Debbie Bowen, Fayette County Schools.
all right, and
Sarah Howard,
Clark County? Okay. All right, is anybody else that I'm missing?
Nicole Brown, Will County School.
Will County. Okay. All right, so thank you very much. So before we get started, I want to introduce Ashley Bush. She's going to come up and talk to us for just a few minutes. She's from the Kentucky Injury Prevention and Research Center, and that is a bona fide agent for the Kentucky Department for Public Health for Community Injury and Violence Prevention. So she's going to talk for just a few minutes about some resources that she has for us.
Hi, everyone. So first of all, I'm at the Kentucky Injury Prevention and Research Center, and I just have a few resources.
If you have not heard about the Purple Star program, how did you all describe the credit? It was the it provides ELI credit. So if you are interested in your school becoming a Purple Star Award school, basically it promotes your school as a military connected school, and you have a training for liaison, and you provide the resources needed to decrease those risk factors and poor injury outcomes that are often seen among those that are military connected youth. And it's called KentuckyPurpleStar.org. And I have some information cards if you're interested. Next up, if you all need injury data, or you're making community planning, curriculum planning, or you need activities for your students, I'd like to introduce you to the Kentucky Safety Prevention and Alignment Network. We all call ourselves KSBAN. If you go to www.safekentucky.org, you can sign up and be a part of the newsletter. But we have injury data there available at the county level. So if you're interested, we have that, and we have some injury prevention for you. So among those, the most recent is one looking at Kentucky adolescent, 10 and under firearm emergency department visits from 2017 through 2021, as well as ATV injuries and drownings. And then lastly, I have some handout. Part of KSBAN, we worked with the Kentucky ESAC and the Office of Drug Control Policy, and we have resources. These include prescription drug lock boxes. There are some for older kids as well as those for younger families 0 to 4. They're free. You just have to sign up, first come, first serve. I have handouts here that you can distribute through your school or community. Thank you.
All right, thank you. Will you put that in the back there? All right, so if I can figure out how to do this. All right, so here we go. All right, so so we are from the Department for Public Health, just so that you all are aware how we work. Angie and I, we talk maybe every day, maybe some days twice a day, but we are connected in all the work that we do. So just letting you know that we are from the Department for Public Health, and that's what this update is going to be for. So the objectives of this part of our training is to define what the school health branch is. It's brand new, and I know you all heard a little bit about it, but we'll give you the goals and objectives. We'll identify the school health branch upcoming resources that we have. We are going to talk about the resources that we have at KDPH as far as it relates to COVID-19, and we are still talking a little bit about that. We are going to talk a little bit about COVID testing and the testing support that's been offered to the schools through the Kentucky Department of Public Health, and we are going to look at the resources that we have to the immunization branch, and we've also got a really exciting announcement today that we're going to talk about. It's a surprise as far as the immunization survey goes. So before we start, so the next thing is, I do want to tell you that the branch has been developed through the Workforce Development Grant at the Department for Public Health. And that is a grant that was awarded so that we can expand the workforce. So part of that grant was to do some work with school health, because I knew there was a big deficit and it was concerned at the Department for Public Health. So that's how we got the school health branch. There was originally a school health consultant, which I was in that position for a while, but basically now we just have a branch and we've got some expanded staff, and I'm going to introduce you to them today. What we're there for is to link you with all of the multidisciplinary teams that we have in the Department for Public Health, epidemiology, and you'll notice in the new school nurse orientation PowerPoints, you'll probably spot some of those new ones that Angie and I put out there. One of them was Epidemiology 101 for school nurses. We developed that one this past fall. We did one on safety after some of you were being threatened and a lot of things were happening at the ground level. So we do have several new ones that we did do together. So our goals are to support quality school health programs and school nursing practice. We're giving consulting information out all the time about delegation, about traits and care. And like I said, Angie and I collaborate on the backside of most of those questions. And I am going to have a couple of slides today on the nebulizer, whether to use it or not. That is the question. So we'll talk about that at the end of the presentation. So I want to talk about this current staffing. So I want to say, first of all, my name is Michelle Malaco. I think a lot of you do know me. I worked at Madison County School District for about 40 years. I was a pediatric nurse working with Drs. Blum, Lewis, and Ramsey in a private pediatric practice, and then went to the local health department to be the school nurse. So I started there in 1992. And then we lived through the era where the health departments lost their funding for the school health programs. They laid down our whole program. At that time, I had 21 staff, and we all were laid off, except for our dental team. They kept the dental hygienist. And then we were picked up by the school district, and so we just continued to carry on. So that was a nightmare, but we made it through that. The next position I want to tell you about is Candace Carpenter, and I want to say hello to Candace. She is watching live, and she could not make it up here today, but she has a bachelor's in social work and a master's in social psychology. So as with mental health, mental health is now the big buzz focus. And we've got Candace now on our team that has a lot of experience working with foster care placements and a lot of, she's done a lot of work with mental health in her private practice. So we're glad to have her, and she's been with us a week. So the next person is.
All right. Hello, everyone. My name is Victoria Smith. I am an administrator alongside Ms. Beth Thomas here. As far as my background, I do have a master's in public health and health promotion and behavior. So I've had some experience working with nonprofit and in the community, working with health departments. I am also a registered nurse, so I get that nursing experience. I've worked acute care in the hospital, a little bit of everything. So it's a combination of experiences that has brought me here, working with kiddos and working with families, and serving our community. So.
Good afternoon. My name's Beth Thomas. The last one, the shortest profile. I've pretty much been in public health, school health for most of my nursing career, for over 22 years in public health and school health. Started out at Lexington State County Health Department, which is kind of where I fell in love with public health, and moved back home to Somerset and started working for the Lakeland District Health Department. Started out as a school nurse in middle school, then I was a supervisor, and then I was the administrator, and so it all came from there. And then I went back to school nurse and health coordinator, and started in June as one of the administrators for the school health branch. So school health is my passion. Glad to be here. It's your turn.
All right. So we have a lot of experience here with school nursing. All right, so
All righty. So I'm going to talk about some of the things that the school health branch is doing as far as some of our new initiatives and things that we are going to be producing and getting out there to our school staff, our school nurses, and the like. So we have talked about, and we're planning on doing virtual networking opportunities. So something where we can come together, ask questions, figure out maybe what some things are that we want to address as the school health branch within our school communities. So as a part of that, having drop-in office hours. So basically, once we're able to coordinate with everybody that's interested, we're going to figure out what's a good time, what's a good day during the week. I think we discuss weekly doing this so that everybody has the opportunity to raise questions or have open conversations about things that we can be doing to improve the community of our schools and promote health for our students. So some of that will be organized to allow school nurses, health staff, the opportunity to, like I said, share ideas, address challenges, and also to get those updates, because with us being a part of the KDPH, working with KDE, there's lots of news and announcements constantly coming out. And although we don't want to inundate you all, we want to make sure that you all are getting the information that you need so that you can take that back to your schools. And then let's see. networking opportunities with not only the district health coordinators, but then also school nurses. We want an inclusive community of all those people that work within our schools and can collaborate with us as part of the school programs. And then, like I said, we will be surveying to determine frequency. Ideally, like we said, we would like to do it once a week, but if that's too much, we could talk about bi-weekly or monthly or whatever works for those that are interested. So keep an eye out for that. And then our website. So it is a work in progress. If you go to the KPH's website and search school health, there's not currently anything there, but it will be a hub of information that we will share as far as resources and sample documents that can be used in clinical school health settings. And then also providing guidance and communication for school nursing and school health services. And an upcoming survey will be included as well regarding what will be helpful to your school for your health programs specifically. So every school has different needs, and we want to understand what those needs are and how we can help provide those resources publicly. And then the newsletter, I think, is a bit exciting because I like publication, I like writing. So this is something that we're working on to produce monthly. And this will be, like I was saying, as similar to our website and those virtual networking sessions. This is going to be where we can announce new information, share some of the things that we are doing. For example, like with the school health branch, we are working on a school staff and student wellness. So lots of fun and exciting upcoming things. So this newsletter will be sent out to our listserv. As far as how to subscribe, Michelle can hopefully give you all more information on that. But it will be something that we will send out via the listserv, and we do really like that feedback and receptivity to know what is good information, what do you all need, what is pertinent, because, you know, we don't want to keep throwing stuff out there that's already out there. So, all right, I'm going to turn it over to Beth now.
We are kind of in the process of starting a new school nurse orientation. We've spoken with several medical agencies that just mentioned that some of the nurses, even though they give them like great support, they still feel like they need more support. And orientation is kind of one of those areas maybe where they've seen could have some improvement. I think the biggest thing is, you know, the school nurse independence is a big thing. So it's kind of like you can have 2 weeks, 4 weeks of orientation with somebody, but it's, you learn something new every day. And sometimes just like being on your own, you just kind of need that added support. So we are working on that. It can be a refresher for seasoned nurses. The course will probably be provided on train. We may do it in person. We kind of talked about that. It's not finalized. Maybe do it this summer in conjunction with the KSNA. Kind of one of our ideas. But we're going to do it on train. Does anybody have a training account, or did you have one in the past? Okay. I guess the big thing with train, it is a little more user-friendly than maybe it used to be in the past. I know when I worked with them for years and years ago, it wasn't always very user-friendly, but it is now. And then it's free. We all love free things, so it will be an opportunity to provide free continuing education credits for us. And again, our survey will include kind of maybe like the needs that you see, like after your orientation. If there's something specifically you would like to see in the new nurse orientation, let us know. And then today, some of our topics for today, we will offer continuing education credits. It hasn't been approved yet, so once today is over, we have our Rick Wheeler is the nurse that approves all of our training and continuing education credits. So she'll review like our slides and our videos and determine how many credits. So we're hoping we can have about 5 continuing education credits. So for you all today, in person and those viewing online, you won't really have to like watch the video again, but there will be like an assessment, so you can kind of like fast forward through the video, take the assessment, and then you can obtain your continuing education credit. So, but then any of your other nurses or school staff who might want to watch who didn't watch today or come in person,
just let them know that's the module number for all of the topics. And I'm not really sure how long the review process takes, but maybe like in a month or so, we will have it all finalized, and then we'll send a notice. We'll email everyone who was participant today and let you know that it's gone live. So you can obtain your CEUs, and hopefully maybe it'll be done before October 31st if anybody still needs teaching education for the licensing period for the time. If not, you have 4 or 5 ready to go for next time. Another person. I don't think there's a copy of the instructions on how to create a training account if you don't already have one. But it is in the PowerPoint, the link. So just click on the link, and I think too, they have to set up your training account at the bottom. It'll say if you forgot your password, if it's been years since you opened your training account. At the bottom, there's a support where you can create a new password and get back in. Seems like there were several people that I know who maybe have had like 2 or 3 different training accounts from different, places of employment. And if you email the training support, they will let you know how to merge all of your past accounts together. Okay. Let me go back to that one slide and let me just tell you. So we're working together. Of course, you've already figured out Angie and I are partners. But when we put the courses on train, it's going to be MCH, which is Maternal Child Health, Kentucky School Health. So, and then in the course title, it will have sponsored by KVE, KVPH. And so we're collaborating on that. So when you go to search, if you want to see any of the classes that we're going to offer from here on out, you can just put Kentucky School Health and then Google that, and then all the courses that we titled to come up with that. Okay. So we did think it was only going to be 4, but we think we may be able to push today to 5, depending on how long each of the sections is. And so fingers crossed, we'll give you some CEUs if you need them. All right, so now so my PowerPoint, we did not copy it because, believe it or not, the process to getting things approved at the DPH is very slow and tedious. So I sent my PowerPoint many times to get approved, and only at the nth hour last night, it finally got a check off, okay? So I apologize for that. But this really is to serve as a DPH resource directory for you. Everything in the PowerPoint, all of the links are live. And I think receiving it on email is going to probably be your best bet. So I don't think that there's a lot of note taking that you might want to do. But anyway, so that's the document. And we'll send that out. Angie will send that out as soon as we can. So it's ready. Now I have to check off on it. So I told him, I said, I'm going to take it anyway. So if you either tell me it's okay now, because I'm leaving the house at 5 a.m. So he got it for me. All right. So anyway, the focus of the DPH now, of course, as you know, is living with COVID. That's the new terminology. Okay. It doesn't mean that because monkeypox is up there and taking over the world up there where we are, that COVID does not still exist, but we're in a new mode. So I do want to tell you that there has been a shift. And everything is pretty much linked with the CDC, okay, which is the way that it should be. We did come out with our update, our school update on August the 1st, and the CDC didn't come out with theirs, I think, until the 11th. But Dr. Winter had been privy to the changes that were happening, and so we were like ahead of the boat. So that's kind of how that works. So these are the messages now that we're saying. Number one thing, get vaccinated, and I've got a couple slides that Dr. White showed at the superintendent's webcast that I included here so that you all can actually see what those slides said and when we talk about the vaccine. And then, of course, there's a link to the guidance for you all to have. I was telling somebody at lunch that back in the height of COVID, I had a superintendent call and ask for some advice. And then I watched the video of him going into his school board meeting and saying, I just talked to the state. And then he gave his own advice. He didn't even say what I said. So so now that we're aligned with the CDC, and there's not this disconnect. Well, what does the state say? What does the CDC say? So that's been the great advantage to kind of aligning things up right now. So anyway, there's no discrepancy there. All right. So
As you know, we did put out a new guidance document, August the 1st, and I would like to get some feedback from you all. So the contact tracing. So are any of you all still doing contact tracing, or did you just jump that ship the minute they said we didn't have to do it? Y'all do, who's still doing contact tracing? Okay. So you're following the guidance. Okay, very, very good. That was the biggest thing I think that we were all glad that did kind of, that it changed a little bit. And that, of course, was reflected in the new guidance. So the layered preventive strategies, you know you know Louisville. I don't know if you all follow, or anybody here from Louisville? Probably not. Well, you know Louisville is following the guidance to the T. And when the community went into the red, they made the children wear masks for that week. So they follow that guidance every week, and they're following all of the strategies that are suggested in that document. So if you hear that they've got their masks on and then they don't have their mask on, you'll understand that they're following the map and what the recommendations are based on that. All right, so this document used to say 10-10-10. Do you all remember that? It was the 10-10-10 document. So this one is the handy thing to have. This is the Bible. This is the number one thing that you should follow if you've got anything taped up to your cabinet inside your clinic or whatever. This is the go-to document for the easiest way to evaluate pages and pages and pages of recommendations. And it's very, very simple. Okay, and so I just wanted to remind you that we do have this, and this is the bottom line. This is the most simple way to determine what's going on and what you should do step by step. All right, so Dr. White included this, and I know this is a little bit busy, and you don't have to look too much on that right-hand side. I just put it off the CDC, but this just shows you the new variant, and this is Omicron right here. BA5. So you can see, and I'm sure you all can really track with your attendance. When Delta came, there were so many people that were so very sick, but now it's Omicron, and you can see that the way that the virus is mutating and how right now I think it's even gone 2 steps beyond that. But this document was pulled on the 10th. So just to see, and it's not as virulent, and it's not as doesn't make people as sick. All right, so the people get this mixed up, and I thought I would put this slide in here just because I want you to know I look at these maps every week, and so the KBPH does post the COVID maps every week. One of them is posted on Friday afternoon, and one of them is posted on Monday by 5. So there are two maps. This is the one that Louisville's following, the community levels by county, to decide whether their kids are masked or not. Okay, this is the one that measures hospital capacity. It measures new cases and how many people are basically in the hospital. So, and this is the one from the CDC. So that one is posted on Friday. So do you ever look at these maps? Do any of you look at the maps? Do you know how to access them? The CDC has a webpage called New and Updated, and I look at that almost every morning to be sure that they don't sneak something on us or change some kind of policy or whatever. So that's where this comes from. But it's interesting to see how the numbers change over time. And I actually post this on our Teams channel under our communicable disease, and I list this every week. And so we can follow the trends and how it's moving. All right, can you all see your hands? They do say that this area right here is less vaccinated. I don't know if that's the case. Is anybody from that area far east? Okay, so do you have a great uptake in vaccines or?
We actually do not have clinics in our schools, but we have a nurse practitioner from the local health department, or King Stars Medical Center, that comes and gets vaccines for us.
Good.
Still not a lot of people are taking advantage of that, even though it's a free service. We do So, I mean, we offer it probably 2 or 3 times a year at least, maybe more.
Okay.
So it's just one of those things that I don't know, it's just, I don't know what it is.
Is it the culture there, or I'm not
It's
sure.
culture, and I'm not, my kid's not taking vaccines, that kind of thing.
Yeah. So, but you can follow the way that goes. Okay, and then this is the one that uses the Kentucky data that we post, the Kentucky Department for Public Health, and this is the current incidence rate. And these two maps are totally different, but I just gave a little summary of the difference here. So these are cases over the past 7 days divided by 7, and then how they figure out based on incidence of 100,000 people. So, but you can still see that over on the eastern part of the state, there is still a high incidence rate. But that incidence rate was 14 this week, and it was 20 last week, and the week before it was like in the 30s, and the week before it was like 42. So as Omicron is increasing and it's not as virulent, then the incidence rate is going down. Which is pretty cool to see anyway. All right, so the testing supplies. So this is the next thing that we've got. So how many of you all are using the testing kits? Or first of all, how many of you all have heard that you can order free COVID testing kits, over-the-counter kits, to give out at the Jumpstart program? They have it at baseball games. They have to send home on library night, or when they come into the book fair. Do you all know that we've got those? You do? Okay. Do you know? Okay, so good. How many of you all have ordered them? Okay, great. All right. So let me just go over this very quickly, just so that you know that we have a lot of them, like a lot of them. So please, please, please order as many as you need, and try and think a little bit out of the box on ways that you can use them. Do you want to have them in a big maybe a basket on the sign-in table when people come into the basketball games? Do you want to give them out to the teachers when they're there at the faculty meeting? Or, they stopped giving them away free at the federal, at the whitehouse.com or whatever, and I ordered every kit that I could from there. But anyway, they are a little pricey if you want to get them, and I pop in every now and again, and I'll just say, my grandson will say, I have a sore throat. I'll say, well, let's just do a COVID test on you because we get them free. See? So I run those through pretty quickly. So anyway, so now we can have 2 different kinds of tests. Let's make sure that I've got this. There's the point of care test. There's 40 tests in a box, but you have to have a CLIA certificate for that. So how many of you all have a CLIA certificate in your school clinics? Okay, great. That's great. When COVID first hit, I wanted Dr. Stack to sign a CLIA certificate for the whole state, for every school nurse office to have access to be able to do testing. And I asked him if he could do that, and he said he didn't think so. So I'm glad that there are several of you that, because of the state being local control, and it was just not the structure of how it was set up. So he just said it would be better if it just kind of bubbled up from the local level. So I'm glad that you all have CLIA certificates. I fought for that at the DPH. I tried to make processes easy, and so there would be no barriers. But things move slow and steady, frankly. So anyway, so do know that they are supplied by the federal government. It is an extended testing program, and school districts are encouraged to use the testing kits and to order them to give away. So, and if you have kids in your office that have, say, a sore throat or whatever, and you're asking the parents to come pick them up and send them home, you could send home a kid if you wanted to. All right, so think of some ways and get some of those ordered. Okay, so who's eligible for the testing? Just like before, it's students and staff and household family members of students and staff. So those can be used in those ways. Any child enrolled in the K-12 school system. If it's a preschool and it's on your campus or it's affiliated with your school system, then of course the preschool does qualify for those. Now, we are rolling this out to daycare centers to be able to offer the over-the-counter kits. But the way that the system has to be set up is the delivery has to be made to the local health department, and then the daycare center will have to go to the local health department to pick up the test, okay, to give away to parents. So it is expanding to the daycare centers. And then any volunteer or any kind of associate that you have coming onto school campus, of course, can also have the kids. So it would absolutely be appropriate when parents come, even for parent-teacher conferences. You could have a barrel of them there by the front door or whatever, so that we could, and of course, that trickles down to us. So if they test and it's positive, they could stay home. So, because we don't want them in school, of course. All right. So the over-the-counter, this is what they look like. These are the ones that I've seen at Walmart. They may be Bionex now and they may not. So at some time when you order it, all of a sudden you used to get Bionex now and then you get a case of another kind of kit. Don't worry about it. It just depends on what supply that we've got in the warehouse and what is expiring the soonest. So those are the kits. And if you all are ordering them, then you know exactly what they look like. But one of those boxes is, I think, $19.99 at Walmart. And all right, yeah, it's about $10 per test. So that's much better. It's much better free than they have to buy them. And so I worried about the point of care test and how, now that they have to be delivered to the address on the CLIA certificate, in my mind, I thought a big semi truck was going to have to pull into the with a big forklift and move the boxes. And I was telling Angie, I said, those schools are not going to like that. That's going to be complicated. It's going to be heavy. And I can just send Cecil and the custodian over to Madison County Health Department to pick up my test and have to have a semi truck. So one of my friends, Michelle Thursday, she said, we've got these in Frankfurt. I said, send me a picture of how big the box is, because I wanted to get that in. I'm very visual. So I wanted to get the look of it and to see. So this is 3 cases. Okay. So there are 16 boxes of 40 tests in each case. So yeah, so they're not that big. You can see it as compared to the door. So just reminding that the CLIA certificate or the waiver has to be in place. You have to train staff. Mainly, the training of the staff is just to keep them from contaminating the specimen and making sure you throw the trash away correctly. Okay, that's a big part of the CLIA waiver, having the CLIA waiver. That you've got to consent, and it's a quick and easy test. All right, and I've included the links, some of the links there for you. Okay. How many of you all do your actual reporting in KHI for positive tests? And do you know what KHI is? Or what is your process for reporting positive tests that you do? Anybody want to? Do you just call the health department and then they put it in? I know that's some of the process. Is it a hard process to put it into KHI? It's not complicated? Okay, good. Okay. I've never done it before. When I first got up there, they sent me to KHI training, and I just lasted 1 day because it was too complicated. I mean, for the backside of it. So I said, that's too much for me. So, okay, so it's not very difficult, and that's good. And just, I think on the horizon, maybe in the next little bit, not a little bit, but maybe in the future, we won't be tracking it for the next, well, in 10 years, we won't be tracking it. I'll just say that. Hopefully before. But there's kind of talk of it. So then this is how to request the test. And you all have seen the paperwork, but this will be in your packet. But I learned something fun about this little icon. Does anybody know why there's a dinosaur in the middle of that? By the way, Dr. White loves that dinosaur. But anyway, somebody told me that when you click that and you're waiting for it to connect, that dinosaur can lead you to some game that you can play on your phone. So I don't know if that's really true or not, but anyway, I thought that was just an interesting tidbit. So. All right, so the other thing about the test, you can order it every month and order as many as you think you might need and then add some more to it. All right? And even Eva in Louisville, she felt that she could only order every other month, but you can order every month or more often if you need it. All right, so remember that the physical address has to be where the CLIA certificate is, and it has to be the district office, so they can't just send it out. And that was a big problem in the beginning. I said the nurses need to have it delivered to their schools, and they just said, that's not going to happen, because then they would have to put in all that data and UPS. It was just very complicated. So that's why it's the district level. And then ordering, of course, the POC test. All right, so the immunization branch. So I do want to introduce Patty Ellis. She's here today. Let's give her an applause for the fun things she brought, with kids, and thank you, Patty, for that. I'm going to let her come up here and talk about the toolkit when we talk about it, but we're just getting up and running in the school health branch, so hopefully next year we'll have our own little ditties. I did bring those green bags, but the immunization branch has got a lot of really cool stuff. So I'll let her talk about the programs that she had on the products back there, and then a little bit about the toolkit. So anyway, we really do appreciate her. So for years and years, I've always done this little update on the immunization branch. Now they have an immunization branch that has thousands of helpers and workers, and they're all doing all kinds of interesting things. And I just said, I got this. So, but maybe next time we'll have them come. I have talked to them though quite a bit, and maybe now that Patty's here and I can say this in front of you all, in front of her too. I want them to develop some training modules. I'll say, put that on train. Let's get some CEUs for it. Let's have just a session on using the immunization registry. And I know they do have a YouTube video that I'll show you and some other things, but I said, try and get it to 50 minutes where we can get some CEUs for it, and that the nurses can access it and research it, and that we all have the same frame of reference and the same data in our data bank as far as how the processes work. So I think they're going to work on that. Although Patty likes to come herself, but I'm asking her to put it on the video. That was one of the first things they had me do when I went to the Department of Public Health, was do a YouTube video, and it was researching immunization records made easy, and it took me upstairs, and it was interesting. But anyway, I think it's doable. So we would appreciate it. All right, so when you get onto the, so I forgot to say, that link right there is to the immunization branch website. Their website is much more than you ever would imagine. It goes deep in the belly of the whale as far as resources are concerned. So that takes you to the front page. And this is a data tracker that's on the top, their front page. And I'm just going to show you kind of how this works. When you take your mouse and you hover over your county, it will show you what your immunization rate was for that county. You can take it out for 6-year-olds, 13-year-olds, and 17-year-olds. You can look at all of these different immunization doses, okay? But it's what's only reported in the registry, okay? So we have discovered that there's really no surefire way to get all the immunization data anywhere, because the only people, and it was out on the listserv yesterday, I think Paula jumped in, Paula Russ from Northern Kentucky, and said that only the VFC providers, which is the Vaccine for Children providers, are required to put it in the registry, and they don't really put it in the registry, okay? They take the coding from their, we call it a PDF, but they take the coding from the PEP, and when they send that charge in for reimbursement, it automatically jumps into the registry. So they're not doing a process like that. If the private pediatricians have an electronic medical record that they can connect to KHI, KHI is the recipient of that data, and then it just dumps it into the registry. If the EMR at the local pediatrician's office had that capability, then it could happen behind the scenes whenever they gave somebody a charge or they put it in their charge system. But because they have to hand put it in and there's no connector to their EMR, it's very complicated. So we'll talk about that in another slide or two, but just to let you know, this is there if you're just interested to look at it. I know this data is 2020, and I have told somebody in the immunization branch, and that's a whole nother story, that it's a year behind, but when you find something like that that's behind and you report it, it can be months and months before it changes. So I've started the process, and hopefully we'll get the 21 data up there. The reports are there, but this interactive map is not there for that data. So it's pretty cool, really. But remember, it's just a snapshot, and it's only part of the real story. All right, so this slide came straight from Dr. White's presentation with the superintendents. And this basically is just a reminder that there's a new bivalent booster. Now, I was in the vaccine study with Johnson & Johnson in the UK. I had 2 J&J shots, and I don't know what to do next. I think it's so complicated that it just keeps getting more and more complicated. Half a dose of this and a quarter dose of that, and the green cap, gray cap, this label, that label. So anyway, I will say that now there's a new bivalent booster. I think the booster series, this is the only boosters that they're using now, and it's for the new Omicron variant. So this is a little more complicated than I really like to put in, but it's called the bivalent, or AKA Omicron. The Pfizer and Moderna both have doses for this, but you can see the Pfizer has only got, can do the 12 and up, and the Moderna is just for 18 and up. And then the number and the timing of the boosters really is related to what you had before. So hopefully you can keep a track of how that works. Okay, all right. So here's the vaccine information website. This is just a slide that Dr. White used that I thought was really nice, that showed the death rates. And this is, of course, over age 50. So you can see vaccinated versus unvaccinated. Okay, Patty, did want to talk a little bit about the toolkit. This is Patty's brainchild right here, and she'll explain why toolkits are important and what we've got here.
I talk with my hands, so I apologize if I pull this away when I'm not supposed to. So Michelle graciously gave us a few minutes to talk with everyone. This is our flu and COVID toolkit. She had shared about the immunization branch main website. Through that website, we have another website called the Immunization Outreach and Education website. So any materials, outreach, or education, any materials that you would want to post in your offices or around the school. The goal is that you would find that information on this website. So this is one of our, you said brainchild, this is kind of an experimental thing that we're doing. With COVID still being very prevalent throughout the state, throughout the world. But now we're getting into flu season. We wanted to put together something where COVID and flu resources would be a one-stop shop. So this document is a virtual toolkit that is located on the Immunization Outreach website. It has flu resources, flu vaccination resources, and just information from the CDC and KDCH about the flu. It has information about COVID-19, and it also has some additional COVID and flu educational resources. So the goal, the reason that we want to do this, we know that the flu season this year is going to be rough on top of COVID. And we know that we're all trying to make sure that everybody's up to date on our boosters, their primary series for COVID. So, but also want to get everyone vaccinated for influenza. So this is on our outreach website. As you can see, there's lots of different links. There's also, I want to point out in the green box up there, flu videos. Multiple organizations, multiple branches throughout the state and throughout KDPH came together. Our chronic diseases group, they were very heavily involved in this project. Earlier this spring, in 2022, they actually filmed educational videos with Kentuckians with chronic health conditions. There's a video in there with someone who has diabetes and the importance of getting your flu vaccination. There's a video in there, someone who has upper respiratory issues,
talking about why they get their flu shot and why it's important. We also have local epidemiologists and community leaders speaking and pediatricians and pediatric nurses speaking on those videos. There's multiple ones. You can actually download those and post those onto social media, if you have a school website and you want to promote those. Those have been approved to be shared throughout. So they are through KVH.
And then,
The toolkit, there is a QR code that you can actually get to our health education and outreach website for immunizations. And there's also the link at the very bottom. So the other thing I wanted to mention, a lot of these social media graphics, you can put those on social media or you can print them out PDF. And they are great for flyers to put around your offices. It talks about the importance of getting flu vaccination, just another reminder for parents. And that is the website. As was said about School Health Branch, this is a very new website, so it's a little sparse. There's not a ton of information, but in the coming months, it will be revamped and redone. And there'll be a lot more additional information on there. So.
okay, so the next new thing that we got is the Kentucky Public Portal, and I did put this out on the listserv so that parents can access their children's records their own self. So do you all remember that coming out, and that we've got that now? So that's all up there too. There is a little video on how to access that you can give parents for that. There is a written instruction sheet on how to do it. It is secure, and it does talk a little bit about what you have to do to be able to prove that that's your child when you're in there for the records. It does give several different options of printing. You can print their full certificate, their full immunization record, which will include their COVID, their HPV, and every single immunization that they've had on the backside. It will print the official certificate, and you do know that COVID does not print on that one. It will also print an official COVID record that you can go in there and get. And then it also will help download a smart health card that you can keep on your phone to use when you travel, for airlines or whatever. And of course, remember that these records may not be complete. When you go to get your COVID vaccine, it may take a week or two for that dose to be actually entered into KHI and then the dose to drop into your record. So there's some information here about why that may happen. Okay, this is the new one. This is the announcement, you all. We need the drum roll. Okay, immunization survey. All right, the Kentucky immunization survey has been delayed. Okay, so in the real world, October 1st, we would want to pull our first report. Okay, and then we pull one of November, and then December, we got to fly with it. All right. So what they're doing is they're reorganizing the survey mechanism from GenLog to RedCap, and it's just the backside of collecting the data, so they're working on that. So the survey deadline has been extended until the end of January. All right, so when you're doing your planning for this, for the rest of the semester, do know that you're going to have, when you come back in January, to pull your final report. And hopefully everybody will go get their vaccines updated over Christmas break on all the records that you're missing. Okay, now the immunization team is going to have an office hours, and they're going to do it every other week. And you can jump on there if you have any questions about filling out the survey, whether you're adding this certificate from that total, and all of those problems that we've had when we filled those out in the past. And that is the time we're probably going to continue with the school health branch. And there's the contacts there. All right. So here we go. To use or not to use? This is the question, the nebulizer. All right. Angie and I have had these questions so many times. We actually sent a survey out to our national partners, and that means we survey all 50 states to get their input. So basically, there's no change, except that we don't have to have a negative pressure limit, which was originally suggested. But so I've given you the link to where these came from. It basically just says procedures that could generate infectious aerosol should be performed cautiously and avoided if appropriate. All right, so that doesn't mean you cannot do it. We've never told you that you cannot do it. All right, so we wanted to just give you the reference here. There are some procedures that are performed, and they're not even saying now that the nebulizer treatment does generate COVID, because The medication is what they breathe in, and the medication comes out, it's when they cough. If the NEB treatment causes them to cough, it's in the cough that is infectious. So these are commonly performed medical procedures that they do say generate aerosols. And then the way they have it set up here is nebulizer administration has started. This all came from the CDC. And it basically says aerosols are generated by nebulizers, are derived from the medication. And it's not from the actual medicine. All right. And then this is just some other information that you still require to wear a mask, of course, and some other rules. All right, so we had somebody yesterday that said, oh, we were never allowed to do these. You guys said we couldn't do it, that we were restricted. So I went back in the research and I pulled this original document. And basically, we never said that. Okay, the KDPH and the KDE never said that. They basically said that it's preferred that we use some other kind of way to deliver the medication, but that nebulizers can be used. And do remember, Angie and I talked about this yesterday. If a doctor orders a NEB treatment for a child, you have to understand that they have considered COVID, right, Angie? And we talked about that. So we have to trust that if the doctor says they must have a nebulizer treatment, then we've got to figure out how to be able to do that. And then I do, one last slide here. I do want you to know, well, two more things, and then I'm finished. You may be contacted by some of your local health departments that have some money or want to come in and do some projects. They were awarded some money to facilitate relationships with the local school districts. And so you may be getting in contact with everyone that want to come and do a disaster preparedness exercise or a resource guide or do some kind of collaborating. They may even offer to give you an emergency kit and set up emergency kits in all your schools. And then last but not least, you know we love Dr. White. She was unable to meet with us to come today, but she sends her hellos and she also sends her thank yous. And so what I want to tell you all today is that Dr. White and the Department for Public Health recognized all the hard work that school nurses did around the COVID-19 nightmare, and I put in the word nightmare, and it didn't get taken out. So I'm glad that you left that in there. And so we purchased everybody's stethoscopes, all the nurses, okay? So what we did was we linked with the list that Angie has in IC to decide how many nurses were where, all right? And we ordered the Littman Lightweight 2 stethoscopes. And I had to justify that because they wanted to get those emergency kit plastic ones that, you know, can't hear out of. But I had to prove that that's what we needed. And we're listening to COVID coughs, right? So we're linking it to COVID. And I said that would be a great gift. And that's why we're going to do it. So, and Beth's got some information, one more slide about how to do that and what we want to do. So anyway, once we get them, they are ordered. They've been ordered for months. There's stuff in whatever process they are in, but there'll be a little thank you card from Dr. White, and we'll decide how many and who to send it to. So, all right. And so, Beth, you want to talk real quick about that, and then we'll be finished with.
Oh, I'll just
okay.
Yeah, like she said, she kind of determined how many to order based on the nurse count from Infinite Campus. So if you're not in there, then I guess you get one. Sorry. Maybe next little gift you might get if you're, but I do think most schools,
yeah, we should have.
There should have been just a handful that did not have any nurses listed in their nurse counts. I know one of the schools, I don't think she's here now, like her nurse count number was double in Infinite Campus. So just kind of connect with your Infinite Campus administrators at your school and just make sure that their nurse count is correct. So obviously we just need to track like who it's going to and we need to send it to just like the one district contact. So I have an Excel spreadsheet. If you want to just email me, I just need your nurses. We would just like to have their email addresses. So just give me a list of your nurses' names and what school they're at. And their name and how it appeared in their email. Like I go by Beth, but I'm Bethany.Thomas. So just however their email name would be, and then the location of their school, your district contact, who I'm going to send them to.
So give me your name and then your mailing address. And my email, like our contact email is at the last, but I'm just bethany.thomas@ky.gov. So, just, you can get with me at the end of the conference, but if you're ready to go home, it's easier just to email me. So, either way, but once they're not, we haven't received them yet. They have been ordered. They're not here yet. So we're going to put that little card in each stethoscope box. And then, once they get here, we will start mailing those out once we get the information from you.
And we've ordered over 1,000, so stop here with your advantage of being here, or at least let us know who you've got. I know I ran over a little bit, I'm sorry. Thank you all so much. And you've got all our contact information if you.
Just a couple quick housekeeping items. If you need an ELIS certificate for today, raise your hand and we will give one to you. Anybody need one? Okay, back here in the back. All right. Michelle, can you make sure? Okay, we've got a couple ladies that need ELIS certificates. All right. Be watching your email. I will be sending out like a survey basically for you to evaluate the training today. And I will also ask you if you have any suggestions for future trainings that you'd like us to do. That'll be coming around in the next, probably around Monday, the first of the week, next week. I will also email out to everyone who signed in today the PowerPoints that we didn't have in your folder. And for those that are watching online, we will have all those posted on our webpage, hopefully next week, that you'll be able to download those. And if anybody didn't sign in on the district health coordinator distribution list, that sheet is floating around here. So if you need to sign up and you didn't get it, let us know, and we will we'll do that as well. So we are going to be before we roll into our next session, just wanted to let everybody know online that we will be ending our webcast now, as this presentation is not something that we're able to broadcast. So those who are attending in person, you lucky folks are get to hear some great information and get some good info. And but other than that, those that are online, thank you for signing in with us today. We hope you learned something. And if there's questions, concerns, anything that's come from today, please shoot me an email and we will do our best to answer your questions and get back to you. And I hope everyone has a great and healthy school year. Thanks, everybody.